Good afternoon. I call this meeting to order. A quorum is present, and without objection, the chair is authorized to declare a recess at any time. Before we proceed, I would like to go over some items for a remote hearing. First, if you are experiencing connectivity issues, please make sure you or your staff connect our designated technical support so those issues can be resolved immediately. Members participating remotely must continue to remain visible on camera for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members participating remotely will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for 2 to 3 seconds before speaking so that your words are captured on the live stream. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. It will be uploaded into the committee document repository. And without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the procedures for this hearing? Hearing none, we will proceed. I will now recognize myself for an opening statement. Today, we come together as we do every September to explicitly shine a spotlight on the prevention of veteran suicide. It is work that requires the collective commitment of us all. VA, VSOs, scientists, researchers, policymakers, advocates, families, caregivers, survivors, and loved ones. The work we all do every day, all year long, to prevent veteran suicide is vital. We talk a lot about systems of care for those in crisis, the Veterans Crisis Line, and for example, a key part of my Compact Act, which would ensure any veteran at imminent risk for harm to self or others can receive free stabilization care at or paid for by VA. I want to make sure all of you, veterans, family members, caregivers, friends, and colleagues, enter the Veterans Crisis Line into your phones in case you or someone you care about needs it. The number is 1-800-273-8255. That's 1-800-2 phone. But I don't want to take up that time right now, but I will. I do carry the card with me. So I think it's a good thing if all of us as members of Congress, we have it into our phones. If we're at a town hall or at a place where we address this topic, it's always great to be able to know that you have it with you. But we also know that a true public health model of prevention is the most comprehensive, holistic approach to suicide prevention, that everything we do upstream to give veterans and their families stability, meaning, purpose, and joy in their lives is also suicide prevention. Stable housing is suicide prevention. Financial security is suicide prevention. Food is suicide prevention. Access to high quality, effective healthcare, including mental health care, is suicide prevention. Education and employment with a living wage are suicide prevention. Preventing and treating the effects of trauma, including sexual assault, is suicide prevention. Addressing social isolation and loneliness is suicide prevention. Encouraging lethal means safety, especially by getting everyone to store their firearms and ammunition safely, is suicide prevention. And treating all veterans with respect, inclusive of their gender, race, ethnicity, and sexual orientation, is suicide prevention. Secretary McDonough's announcement to begin providing full benefits and services to LGBTQ plus veterans who served and were discharged under Don't Ask, Don't Tell is suicide prevention. Now, we will hear this morning about VA's ongoing and new suicide research studies and how science and innovation both guide VA's broad and targeted efforts to prevent veteran suicide. We want to know what works and what looks promising. And I'm also eager to hear about how VA has tailored and expanded its mental health support and suicide prevention outreach in the wake of the ongoing pandemic and the recent U.S. withdrawal from Afghanistan. Now, this hearing was planned long before the most recent events in Afghanistan, but I have asked VA, VSOs, and the veteran witnesses to share what they have been doing in terms of outreach and additional support for veterans who are struggling. My staff has been in daily contact with VA, VSOs, and mental health organizations this past month. And I thank you for keeping them briefed on your needs and your efforts. Veterans are not a monolithic group, and though all have worn the uniform and served this country, they all bring unique backgrounds, experiences, strengths, and challenges to their service and the next phases of their lives. This means that just as there is no single cause of suicide, there is no single approach to preventing suicide. Our shared goal is to dial down the risk factors in veterans' lives while dialing up the protective factors. With this goal in mind, I've directed my staff to put together a legislative package of mental health and suicide prevention bills that we can move with the urgency we all agree is warranted. And they have invited Republican staff to provide input as well. This new mental health and suicide prevention legislative package will include provisions to improve how VA trains its community mental health service providers. Community mental health providers. Increase the number of peer specialists in VA medical centers. Expand VA's lethal means safety training. Auto-enroll service members separating from active duty in VA databases during the transition process. Strengthen and add more resources for the Veterans Crisis Line. Increase the number of vet centers around the country, and ensure that suicide prevention outreach and care reaches traditionally underserved veteran communities. On that note, I just introduced a bill with Congresswomen Porter and Slotkin, the VA Governor's Challenge Expansion Act. Our bill directs VA to treat tribes equal to the states for the purposes of the VA Governor's Challenge program. It also gives VA new authority to use existing funds to help states and tribes not just develop, but implement promising veteran suicide proposals tailored to what veterans and their communities need. I know we all were really pleased to hear that in 2019, the most recent year for which the CDC and VA have reliable suicide death data, that the rate of suicide among all US adults, but especially veterans, went down. The number and the rate of suicide among veterans decreased for the first time in many, many years. While this is wonderful news, all of us know that it doesn't pause our commitment and our work for even 1 second. One veteran dying by suicide is one too heartbreakingly many. And with that, I look forward to hearing from the witnesses on both of our panels. Ranking Member Bost, I now recognize you for 5 minutes for your opening remarks.
Thank you, Mr. Chairman. I appreciate the opportunity today to discuss the tragedy of veteran suicide and how to prevent it once and for all. September is National Suicide Prevention Awareness Month, and this September, there's cause for celebration and caution. 2 weeks ago, VA released 2021 Veteran Suicide Data Report. For the first time in a long time, as the chairman said, the report contained good news. In particular, it showed that 7.2% decrease in veteran suicide in 2019, the most recent year for which we have data and that's available. And according to the VA, that's unheard of progress. But as we all know, the last 2 years have brought unheard of challenges as well. Those challenges include COVID-19 crisis, and more recently, the crisis caused by the Biden administration's failure to withdraw from Afghanistan properly. Veterans who served in Afghanistan, and even those who serve elsewhere, have been under immense stress watching the tragic events of the last several weeks unfold. And I've felt that same stress as well. And according to the VA, compared to the same time period in 2020, from August 13th to September 15th, the Veterans Crisis Line experienced a 6% increase in calls, a 32% increase in chat, and 71% increase in text. Those increases are a direct result of the crisis in Afghanistan. They paint a stark picture of the pain that many veterans are experiencing at this moment. It is our responsibility as members of this committee to do everything in our power to support those veterans and to make sure that we have what they need to heal and move forward. That's why my fellow Republicans and I have been calling on Chairman Takano to schedule the oversight hearing to address the impact of Afghanistan crisis it is having on our veterans communities. This is not that hearing. Our calls have gone unanswered, but we must use this opportunity nevertheless to shine a light on those in need. That is why I'm honored to have Nick Armendariz here to testify as a minority witness today. Nick is an Army veteran who has served. Nick is an Army veteran who has served 3 combat tours in Afghanistan. He transitioned out of the military 8 years ago in 2013. He has been frank about the battles he's faced since then and his own mental issues that he's dealt with. He will be frank today about just how devastating the last several weeks have been for him and for many other veterans. And Nick, we thank you. We thank you for your service in uniform, and we thank you for your service that you're doing here today. Your pain is not just your own. It is shared by many of your brothers and sisters in arms across this country. By giving voice to your experience, you are powerfully showing that veterans, that they are not alone, and that there is strength and hope on the other side of every struggle. It really is okay to not be okay. If you are a veteran who is watching this right now who needs help, please know help is available to you anytime. And I know that the chairman mentioned this, but I think it's important that if you're listening here today, that we do mention this. You can receive help by calling 1-800-273-8255 and pressing 1. That's 1-800-273-8255 and pressing 1. Or you can text 838-255, and that's 838-255. Or you can visit the crisisline.net for help as well. Mr. Chairman, with that, I yield back.
I want to thank the ranking member for mentioning the Veterans Crisis Line and for modeling. I think what we all should be doing as members is to, whenever we talk about suicide prevention or the topic, we also mention how folks can get help. And so, ranking member, it was a pleasure to spend time with you in Southern California.
Really enjoyed it.
I just want to say just how much I appreciate the relationship that we're developing. We don't agree on many things, but we agree on a lot of things. And I think that typifies the membership of our committee. We are very passionate about our points of view, but I think we share a very common passion for those who've served our nation in uniform. So I want to express what an honor it is to always serve with actually not only a ranking member, but someone who comes from a great military family who was a Marine himself. So thank you so much.
Thank you.
I will now call up and recognize our first witness panel from VHA. Dr. Cameron Matthews, Assistant Undersecretary for Health for Clinical Services within VHA. She is accompanied by Dr. Matthew Miller, Executive Director of the Suicide Prevention Program within VHA's Office of Mental Health and Suicide Prevention. Dr. Lisa Brenner, Director of VHA's Rocky Mountain Mental Illness Research Education and Clinical Center for Suicide Prevention. Thank you all for being here. And I will remind our witnesses to pause for 2 to 3 seconds before speaking and answering questions. Dr. Matthews, you're recognized for 5 minutes to present VA's testimony.
Thank you very much, sir. Good morning, Chairman Takano, Ranking Member Bost, and distinguished members of the committee. My colleagues and I appreciate the opportunity to talk about the great things VA has done and will continue to do related to suicide prevention. I'm accompanied today by Dr. Matthew Miller and by Dr. Lisa Brenner. We would like to express our gratitude to each of you for joint efforts with us in ensuring veterans are aware of resources of support, including the Veterans Crisis Line, in response to recent events in Afghanistan, and for all your commitment to veteran suicide prevention across many levels. I want specifically to thank the House for passing a strong military construction, veteran affairs, and related agencies funding bill. Of note, the bill includes robust funding for mental health and includes the $599 million requested specifically for suicide prevention activities. This funding is critical to the continued focus on our suicide prevention efforts and the VCL implementation of the new 988 number. In 2019, 45,861 adult Americans died by suicide. Of those, 6,261 were veterans. These numbers are more than statistics. They reflect individual lives ended before their full stories were written. With each loss for each family, we continue to rededicate with each of you a commitment to the mission to address suicide as a national public health concern. Suicide has no single cause and no one set solution. Our work continues now in partnership with each of you to operationalize the public health approach in the National Strategy for Preventing Veteran Suicide, combining community and clinical strategies to reach all veterans. This strategic plan is being actively implemented through deployment of the Suicide Prevention 2.0 initiative, the Suicide Prevention Now initiative, the President's Roadmap to Empower Veterans and End a National Tragedy of Suicide or Prevents, 988 and the VCL expansion, as well as the implementation of ongoing research advancements and their translation into practice. In addition to these initiatives, our efforts are now further fueled by the Commander John Scott Hannon Veterans Mental Health Care Improvement Act of 2019, the Hannon Act, and the Veterans Comprehensive Prevention, Access to Care and Treatment Act of 2020, the Compact Act. The Hannon Act will provide critical mental health care resources and evaluate alternative and supportive treatments to clinical care for veteran populations through VA, as well as provide financial assistance to eligible entities through the award of grants to such entities to provide or support the provision of suicide prevention services to eligible individuals and their families. The Compact Act authorizes VA to implement programs, policies, and reports related to transitioning service members, suicide prevention and crisis services, mental health education and treatment, and improvement for services for women veterans. Section 201 specifically of the Compact Act requires VA to furnish emergent suicide care to an eligible individual at a medical facility of the department, pay for emergent suicide care provided to an eligible individual at a non-department facility, or reimburse an eligible individually for emergent suicide care provided to the eligible individual at a non-departmental facility. The provision of benefits under this new authority requires considerable time to implement, and VA is working rapidly to develop a process to ensure the Office of Community Care is notified whenever an emergency dispatch or facility transport plan results in a veteran receiving care at a community facility. Additionally, the Veterans Benefits Administration provides a variety of benefits and services upstream, which can help reduce or eliminate risk factors associated with suicide and promote protective factors for some veterans. Programs such as Solid Start, disability compensation, pension, veteran readiness, and employment and education assist veterans with transitioning to civilian life, connecting with benefits, establishing and achieving educational and vocational and career goals, and supporting financial well-being. Finally, VA is committed to growth of suicide prevention research to inform and advance our knowledge base. VA's Office of Research and Development and the Office of Mental Health and Suicide Prevention work together to ensure that research inquiries and funding are synchronized with operational priorities aligned with the National Strategy of Preventing Veteran Suicide. Anchored in hope, we hold to our core tenets. Number one, suicide is preventable. Number two, suicide prevention requires a public health approach, combining clinical and community-based strategies. And number three, everyone has a role to play in suicide prevention. Suicide prevention will take all of us, including all of you, and all of our communities across the nation. We appreciate the committee's continued support and encouragement as we identify challenges and find new ways to care for veterans. This concludes my testimony. My colleagues and I are prepared to respond to any questions you may have.
Thank you, Dr. Matthews. Without objection, your written testimony in full will be included in the hearing record. I now recognize myself for 5 minutes of questions. Dr. Matthews, I'm impressed with how VA immediately provided resources for veterans in the wake of the U.S. withdrawal from Afghanistan. This is of paramount importance to me and this committee. Is there more you want to share about VA's efforts?
Thank you so much for the acknowledgement, sir, for the question. Really, we were quite interested to really have a multi-pronged approach to ensure that veterans who were impacted by the events in Afghanistan knew that they were not alone. That was consistent messaging that we shared through a multitude of different opportunities and resources, through different blogs, emails that went to millions of veterans nationwide, daily outlets, through our Veterans News Network, through Vet Resources check-ins, different media interviews, even our facilities holding town halls, observance events, support groups. There's a multitude of different resources that we have purposefully made widely available, with just acknowledging that we need to talk about it. In fact, that's our tagline, let's talk about it. They are not alone. That was emphasized time and time again. And really the concept that VA is here for them, that we are regularly available through a multitude of resources, whether it's through the VCL, whether it's through online opportunities and chat events, or whether it's directly at a facility where they can sit face-to-face with a provider, with a support team. These are numerous examples that we hope veterans really have been benefiting from. We've been getting that feedback ourselves, even the proactive outreach that we've done just through emails alone. The response that we get has been really telling, and we will continue these efforts as much as needed to make sure, again, that they realize that VA is here for each and every one of them.
Well, thank you, Dr. Matthews. If I turn to Dr. Miller, I'm really glad that VA is no longer afraid to have conversations with veterans about their firearms. Can you reassure my colleagues that this is not only important, but an expansion of something VA is already doing successfully to drop the suicide rates among veterans and others living in their homes?
Yes, sir. Thank you for the question and for the spotlight focus on lethal means safety, and in particular firearm related lethal means safety. You, in your introductory statement, accurately asserted that there is no one single explanation for suicide, and there is no one solution. It involves, as you highlighted, maximizing protective factors, minimizing risk factors, and those risk and protective factors have to be explored and enacted across clinical and community-based settings. Now, take the facts that we have just talked about with regard to multiple reasons, multiple causes, and think of it in terms of the following. All of those multiple causes, all of those multiple factors, 70% of the time come down to one lethal means, and that's firearms for veterans. So as our clinical practice guidelines demonstrate and the research demonstrates, one of the most important things you can do in suicide prevention is, yes, explore risks, explore preventative factors, explore policy and interventions that can address those. But as we're exploring the whys, if you will, of suicide, don't forget the how. And when the how is explained 70% of the time by one thing, a firearm, that suggests that it's a very important area to focus upon. Therefore, in this year, we are addressing the issue aggressively through our lethal means safety campaign.
Dr. Miller, with like remaining 30 seconds, I want to get to Dr. Brenner. But thank you. I know that other members will be wanting to explore this more in depth with you. But Dr. Brenner, VA's research program is often a hidden gem. Can you say more about what VA has learned about suicide from the genome sequencing and the Million Veterans Project and what it hopes to learn from the ASCEND study?
Yes, thank you. Thank you, Chairman, for both those questions. And I think they're related, those two studies. I think as Dr. Miller highlighted, what we're trying to do is understand how to put different risk and protective factors together, and in doing so, do a better job at predicting suicide. Both the MVP project with genetics and the ASCEND project with important information about non-fatal suicidal behavior in veterans who may or may not seek care in the VA can be combined to look at predictive models and identify those who we may not always know who are at risk at this point.
Thank you very much, and thank you for answering so briefly. I apologize for going over time myself. I now want to yield back and call on Ranking Member Boss for 5 minutes.
Thank you, Mr. Chairman. You know, Dr. Matthews, you kind of went into where we're dealing with the Afghanistan situation with what we're doing passively, and I'm glad to hear that we're talking with them. But I was alarmed to hear that VA they never made a national target outreach effort, the plan to connect with the veterans who may have had an increased risk for suicide due to the ongoing crisis in Afghanistan. We know that many veterans are suffering because of this failed withdrawal and the problems that came out of it. So what is the VA's responsibility in reaching out and making, and supporting them and actually bring, as we see the uptick that I talked about in my opening statement, why has there been no national outreach effort that's been done by the VA?
Thank you for the question, sir. There actually has been a considerable amount of proactive outreach through even our VCL line, through our Office of Social Work, through our post 9/11 case management program. Individual facilities are reaching out to those veterans who are at high risk for suicide. There's been a considerable amount of engagement in that effort proactively. Matt, I don't know if there's additional information you can share from your perspective.
Sure. Considering this from a public health perspective means that we engage outreach in at least 3 target populations: universal, which means outreach to everyone in the population; selected, which means those who are at elevated risk; and then indicated, those that are at the highest risk. Our paid media has been structured to outreach and specifically target each segments of those populations. Within the present month, we've engaged 2 radio media tours into 50+ markets to talk specifically about resources available to veterans, including post 9/11 veterans, and to offer follow-up resources and ways to connect. Taken in total, looking at 1.2 billion impressions for our paid media websites, 3.3 million website visits, 404 million video views, and 94,000 resource engagements, which means the veterans are diving deeper into links and resources that are provided.
Good. Dr. Matthews also on our next panel, Mr. Armendez, he's going to testify that regular hearings from the veterans who cannot gain, he's hearing from veterans who cannot gain access to VA mental health care or do not trust it. Okay, here's the claims, and I just need to find out. Some veterans experience wait times of up to 10 weeks and are not being given the option to seek care in the community despite being eligible for it under the Mission Act. We've heard that well, actually quite a bit. Those are various charges that are going to be out there that will come up in the next hearing. So can I have your response to that now? I wish we could put both of them together so we could actually have that conversation.
I too, sir. Thank you for that question. Really, as you know, with my history in community care with the Mission Act, this is by all means unacceptable through VA. We would certainly like to address any individual concerns of veterans that are having those issues. Please share that information. I'd be happy to work with the gentleman on the next panel. We are in every way looking to, of course, increase availability and capacity of mental health services within VA, but are in every way supportive of assuring that veterans that need and have eligibility for community care are also receiving those services in the community.
Okay, so what should they do in a real short period of time? And I wish I could have a little more time, but if they're seeking an appointment, or they told that they have a long wait time, or not being given the opportunity for community care, how do they reach out so that they know how to respond?
Yeah, they can certainly work with their patient advocate at the facility, but if you know of individuals that need assistance, we can definitely work with your office to assist them directly as well.
I appreciate that, and I hope all the other members are listening to that too, that we would be able to use our offices as that springboard to get to you if need be. So with that, I'm out of time and I yield back. Thank you, Mr. Chairman.
Thank you, Ranking Member Bost. I now call upon Representative Brownlee, Chair of our Health Subcommittee, for 5 minutes.
Thank you, Mr. Chairman, and thank the panelists for being here. My first question to Dr. Matthews, and you stated in your testimony that there's been a 13% decrease in the number of women veterans who died by suicide. Can you talk a little bit about what VA is doing very specifically to address the unique mental health needs of our women veterans?
Thank you so much, Congresswoman. This of course is of paramount importance as we do, of course, strongly value our women veterans. We offer a full continuum of gender sensitive and, most importantly, evidence informed mental health services to meet women veterans needs through either mental health providers, more than half of which are female themselves, but also through our women's mental health champions designated at every facility to truly support them. We are also, of course, concerned about reproductive mental health needs. So our consultation program is quite strong. We're focused, of course, on eating disorder and other more specific disease states. We acknowledge the clinical complexity around women veterans, being that over 40% of women veterans actually have been diagnosed with at least one mental health condition. So the need for this sort of targeted services is readily paramount. Our training initiatives are quite strong. You're aware of our many residencies, of our increasing mental health training through the STAIR program. So we will continue to expand and, most importantly, recruit additional providers with a focus on women's mental health.
Thank you. And I think in the Deborah Sampson bill, there was a piece around making a pilot program, a permanent program within the VA for retreat settings for women that have been deemed successful mental health wise. Is that happening?
Ma'am, I'd have to get back with you and confer with Dr. Hayes just about the current progress of that, but we are certainly committed to implementing the entirety of the Sampson Act.
Thank you. And Dr. Brenner, I was excited to hear about the ongoing research you and your team are doing on suicide prevention. So what are, from your vantage point, what are the biggest challenges doing your research, and how can Congress be supportive of your efforts?
Well, I have to say that I have the opportunity to do research in a number of different settings. And I really appreciate your question, Congresswoman, because VA is such an amazing setting to actually do research in. And part of that is because the veterans are so willing to participate. And for example, on your last question about women veterans, we know that not only do women veterans need services, but they may need services that meet their specific needs. They may have different preferences than other veterans, and we may need to do things in different settings. So one of our researchers, Lindsay Monteith, has been looking at how can we possibly use reproductive care settings with our partner Claire Hoffmeyer, how could we bring suicide prevention into reproductive care settings where patients really trust their providers and then really match those two things. So I think continuing to have access to the resources that we have, and some of it very specific to technology, but VA is a terrific place to do research.
Great. So this question is, I think, both to Dr. Matthews and Dr. Brenner both. But so, one of the things the gentleman from RAN is going to be testifying in the next panel. He talks about, the need for more current data, and the VA, that data lags usually by a 2-year period. What can VA do to, have more current data so that we're actually dealing with real data, timely data in terms of responding to programmatic needs within the organization?
I'm happy to respond to that, Dr. Matthews. So some of the challenges are related to the data that we receive from CDC. And so the lag is a little bit kind of outside of our control in terms of death data. But one thing the leadership in OMHSP has funded this Ascend project. And what the Ascend project is lets us collect data in more real time around factors really that are pertinent to veterans who are living in perhaps rural areas, women veterans, veterans who we've had trouble reaching in the past, so we can have real-time data about things that drive risk and things that are protective. Not only can we do this in real time, but we can also change questions in real time. So just recently, we added a number of questions about COVID and the impact of COVID on suicide risk, and this lets us actually respond more quickly to current crises.
Thank you so much, and I yield back, Mr. Chairman.
Thank you, Chairwoman Brownlee. I now recognize General Bergman for 5 minutes. General?
Yeah, thank you, Mr. Chairman. And Dr. Matthews, Section 201 of the Hannon Act contains my legislation, the Improve Act, which establishes a grant program to support services to at-risk veterans and their families. As a veteran and someone who has spent a fair amount of time over the last several weeks talking to veterans in my district and elsewhere, I can tell you that veterans are struggling right now. The failure in Afghanistan has caused a lot of painful memories to resurface. I worry that we will be grappling with the impact of that for a long time to come. That makes the Improve Act much more important than ever before. What actions are you taking to expedite the implementation of the Improve Act, and how soon will VA be able to deliver grants through the Improve Act?
Thank you so much, sir. We could not agree more that this level of emergent suicide care and its coverage is critical. We are working on our existing processes. As you're aware, with the Mission Act, we really were able to add a lot of efficiencies to how we move forward with paying for that care in the community. We definitely want to assure that we have good quality oversight of a lot of this good care, that we are making sure that we're appropriately also, unfortunately, administratively making sure that veterans aren't facing bills for this care when they actually are seen in emergency rooms around the country. And we are either paying directly for that claim or reimbursing for it. As you remember well, with our claims backlog in the past, that was a huge disservice to veterans that was the case. So we want to make sure we do this right. We want to make sure that the regulations are appropriately reflecting how these claims will be billed. It's really not an issue about where they'll be receiving this care, but more so how can we assure that it's being structured appropriately. There is the additional expansion as well too, which we are equally as committed to. This actually expanded the eligibility of individuals, including those who are not enrolled in VA. If we do not structure this appropriately, the processes of how this care can be coordinated, they might as well be billed, and that is equally as unacceptable. So we are quickly moving forward with those regulations as quick as possible with our partners in OMB, and we look forward to sometime in 22 to have those regulations published and moving forward.
Good. What do you think in specific you need from Congress?
I think I heard, Sarah, do we need anything specifically from Congress? I'm sorry you broke up there. No, sorry, at this point, we are moving forward at a steady clip. No further assistance is needed. We appreciate this legislation and we're looking forward to implementing.
Okay, because I can't see how much time do I have left on the clock?
Minute 45, sir.
Okay, then I'll just, Dr. Matthews, as a Prevents ambassador, I think that the Prevents Task Force did excellent life-saving work for veterans under the Trump administration. And part of that was due to the role it had outside of the VA, where it was able to leverage an all-of-government approach to suicide prevention. That is critical because, as you have admitted this morning, preventing suicide requires everyone to play a role, not just those within the VA healthcare system. Given that, Ranking Member Boston and I wrote to the VA earlier this Congress to express our concerns about Prevents moving inside the VA, allegedly because it was not. What impact has that move had on the work being done on Prevents, and how is Prevents continuing to lead the charge?
Before I defer to Dr. Miller, who's actually serving in the current role of Executive Director over Prevents, I would definitely state that we've had no hesitation whatsoever in the forward motion of achieving the goals on the roadmap. Our lethal means safety campaign has moved forward quite steadily, as Dr. Miller referred to earlier. So I see really no pause in those efforts at all. Dr. Miller, do you have additional points?
100% correct, Dr. Matthews. We are in the implementation phase of the firearm lethal means safety outreach, which is directly tied to and a reflection of roadmap recommendations 1 and 8 integrated together. In FY22, we'll be moving forward with that and expanding across at least 3 tracks addressing lethal means safety, a track specifically for veterans, one for family, loved ones, and community members, and one for healthcare systems. We're also working from an interagency perspective within the government, where lethal means safety is one of 4 primary goals and domains for interagency collaboration and coordination.
Okay, well, thank you. And I'm sure my time is past. I yield back.
Yeah, thank you, General Bergman. I now recognize Representative Lamb for 5 minutes. Representative.
Thank you all. Thank you, Mr. Chairman, and thank you for the panelists joining us. Good news on 2019, of course. My suspicion, strong suspicion, is that the 2020 numbers may be tougher to take once they come in, just given the type of year it was. We know, particularly with respect to drug overdoses in our country, it was the worst year ever. And I'm sure the veterans population was affected as well. I wanted to ask Dr. Matthews a little bit about the peer support outreach program and the peer support specialists. I know somebody, actually somebody I served with who works in that capacity already, who received excellent care and treatment over a long period of time at the VA outside of Pittsburgh, and is now able to sort of give back to other veterans. And so I was hoping you could delineate for us how that program is operating every day, particularly the participation in it of people who've suffered sort of mental health conditions, non-substance related, and those that are substance related. Are those types of veterans sort of targeting their own kind, or is everybody kind of working in it together? And is this a program that you could see us growing over time? Obviously, we're going to have a lot of veterans suffer from these conditions. And do you think there's promise in their peers along the way?
Such an important question. Sorry, I'm going to defer straight to Matt just to be quick with the answer.
Oh, great. Thank you. Yeah, that's fine.
Yeah.
Thank you.
Yeah, I think one important area that we're very excited to share in terms of peer support and demonstrative of expanding peer support services is the fact that this year, the Veterans Crisis Line initiated a peer support outreach call center. And that was developed with the mission to provide support, hope, recovery-oriented services to veterans who are identified as being high risk. They're calling the VCL, but then from a beyond the call perspective, it's having veterans who are peer support specialists reaching out to those VCL callers and offering follow-up contact, follow through with regard to access to services. That initiated earlier this year. We're very excited about it and hearing great feedback from veteran VCL callers who have appreciated this extension of peer support services.
It's great work, and it provides a very concrete and tangible future, I think, to the people who are going through recovery in the VA system, that this is an area where they could work afterward and put their skills and knowledge to work. Is there any kind of formal evaluation or data collection or research being done on the program to help us understand? I think sometimes we feel like we're throwing a lot of different things at the wall in mental health, as we should, but would you say that VA is evaluating this program as we go with an eye toward expanding it if that is warranted?
Dr. Matthews, if you would prefer for me to address that, I would be happy to
please,
do
Matt,
so.
jump in.
Program evaluation, sir, is a critical component of any program that we initiate within suicide prevention, within mental health as a whole. We have program evaluation tied to our beyond the call efforts within the VCL, which includes the peer support outreach center and includes the caring contacts that we have initiated to veterans. That is also a peer-to-peer based format. We have program evaluation built in for and will expect to report upon SP 2.0 in both the clinical and the community domains. An important area to watch for therein, in light of your questions, is the Together with Veterans program and the progress that's being made with that, because that is a peer-to-peer based program within the community.
Thank you. I think there's a lot of promise in this idea. And I think because especially I've seen it up close, and, just while you're serving, that ethic of kind of looking out for the person to your right and left is so instilled in you. I think it has a lot of promise. So please share those evaluations and data with us as they come in. I'm sure the whole committee would be interested in it. And
Yes,
we're
sir.
always looking for places to invest if they're having a lot of success. So I thank you all for your service. And Mr. Chairman, I yield back.
Thank you, Mr. Lamb, for those questions. I too have seen some of the results of this up close. I know that we've had bipartisan legislation on the peer support specialists prior, but I am intently watching what is going on with this program. And I want to encourage our Republican members to also look. This is an area that I think we could build consensus around and ramp up our workforce more quickly, or expand our workforce more quickly, and have it be more diverse. So we have relatable folks within our mental health workforce. That's one of the complaints I'm hearing from veterans, is the relatability in terms of the diversity of our workforce. Representative Banks, I recognize you for 5 minutes.
Thank you, Mr. Chairman. Last Congress, Ranking Member Bust and I were proud to co-introduce the Support for Suicide Prevention Coordinators Act that President Trump signed into law. The legislation required the Government Accountability Office to conduct an assessment of the responsibilities, workload, and vacancy rates of VA suicide prevention coordinators. In many instances, suicide prevention coordinators reported being overworked and unable to keep up with their many responsibilities. Some medical centers didn't even have an SPC on staff. As a follow-up, Ranking Member Botts and I co-introduced the Access to Suicide Prevention Coordinators Act, which was also signed into law by President Trump as part of the groundbreaking Commander John Scott Hannon Veterans Mental Health Care Improvement Act. This important legislation required the VA to employ at least one SPC at each VA medical facility across the country within 1 year and required the VA to implement the findings of the GAO report on SPCs. Dr. Matthews, can you give us an update? Can you give an update to the committee on whether the VA has or is close to implementing the SPC staffing requirements or the findings of the GAO report?
Sure. Yes, we are. We are moving forward with not only some internal staffing assessments, but the broader evaluation that was prescribed, as you described in the Hannon Act, definitely.
Do we have a SPC on site at each medical facility in the country today?
Matt, can you confirm that at this point?
Yes, out of 140 facilities as of this day right now, and the information that we have available, we have 135 out of 140 with one suicide prevention coordinator at least. We have 0 with no suicide prevention coordinator or suicide prevention care manager. We have 5, which accounts for the difference I'm sure you calculated in your head, that are below 1.0 right now. And we continue to work with those 5 facilities as well as facilities as a whole with their SPC staffing.
Great. An April 2021 report from the GAO found that the VHA has, quote, not conducted a comprehensive evaluation of local suicide prevention teams, including an assessment of any challenges teams face in implementing VHA policies and the effects of program growth on workload, end quote. The report goes on to say that, quote, without an evaluation, VHA does not have a good understanding of how its various activities and initiatives are affecting teams, including any effects on the care teams provide veterans who may be at risk for suicide, end quote. Dr. Miller, does VHA plan to conduct a comprehensive evaluation of local suicide prevention teams to help address the challenges they face and ensure our nation's heroes are receiving the best frontline care as possible?
Yes, sir. It's in process. We have 2 actually broad initiatives that are in process in response to this. First, you mentioned, and thank you for bringing it up, Section 506 of the Hannon Act. With regard to Section 506 of the Hannon Act, we are pursuing a formal exploration, and it's engaged with an external contractor to assist in terms of what is the best alignment, national to local, with regard to SPCs, to make sure that they are adequately and fully supported administratively and clinically. We've also initiated a suicide prevention coordinator staffing model. The review is completed in a preliminary format. It's a productivity-based model. It's similar to the caregiver staffing model. And that is then in motion as well.
I appreciate those updates very much. Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Representative Banks. I now recognize Representative Levin, Chair of our Economic Opportunity Subcommittee, for 5 minutes.
Thank you very much, Mr. Chairman. Dr. Matthews, I appreciated your testimony about the steps the Veterans Crisis Line has taken to meet the needs of veterans who might be struggling with the recent events in Afghanistan. Can you describe the resources VCL collected from other agencies and disseminated to the call center staff?
Sorry, I'm sorry, you broke up there. I think you were asking about information collected by the VCL from other agencies. I think I heard that part correct, right?
That is correct.
Okay, great. Yes, sir. I'll defer to Matt on some details, but I am aware that the VCL not only is being quite proactive in making sure that we are appropriately staffed throughout all shifts. This is a 24/7 process here, that we're disseminating resources not only from other agencies like SAMHSA and DHA, but also the American Red Cross, the of course internal resources like our own National Center for PTSD. Those resources are being disseminated throughout the staff, and of course I think quite critically, we need to recognize we're also providing a significant amount of support for the staff themselves, many of whom are actually veterans, many of whom are feeling what we call somewhat the vicarious trauma of really working with others in these really touching moments. Anything, Matt, that you would add to that?
I think you covered it very nicely, Dr. Matthews. I think just my summary response would be Dr. Lisa Kearney and the VCL team have responded rapidly in at least 5 key areas in response to the Afghanistan situation. Number 1, partner engagement. Number 2, dissemination of resources internally and externally through federal working government groups. Number 3, identifying supports for VCL staff as they were engaged in their frontline work. 4, appropriate preparation for increased volume, adjusting capacity vis-a-vis demand. And then finally, enhanced data monitoring, which allowed us to quickly better understand what we were seeing in terms of demand. For example, quickly,
let me get to my other questions, if I might, Dr. Miller, but I appreciate that response, and perhaps my next question will allow you to continue your answer. I understand you've seen a surge in call, chat, and text volume in the last several weeks. So first, I'm curious what trends you're seeing with regard to the number of calls that relate to the events in Afghanistan. And then secondly, well, VCL is a vital resource for veterans in crisis. I think we also have to work to connect with and support veterans before they reach that point. Earlier this month, I led several colleagues in writing a bipartisan letter urging VA to develop a comprehensive post 9/11 veteran outreach plan. So what is VA doing to proactively contact these veterans, especially these veterans who served in Afghanistan, and to connect them with local resources?
Great. So the first part of your, I think, comments and questions gets exactly at what I was heading. You asked about themes and trends that we're seeing within the VCL. Because of the data monitoring and the changes that were put in place, we can see that about 2% of the total incoming demand for the VCL during this time has been directly attributable to Afghanistan, as stated by the responder who's working the situation. About 5 to 6% of the time on average, Afghanistan is noted within the documentation, but is not necessarily cited as the primary reason for calling. So 2%, 5%, important to understand contextually in light of the recent surge of demand. In terms of that which we are engaging for outreach to all veterans, this is where our Reach Out campaign comes into place, which is a partnership between Suicide Prevention and Prevents. And as I mentioned, we've been hitting the radio media tour heavily this month to talk about the Reach Out campaign, to direct individuals to the landing page. And then that provides direct resources, including local resources based upon zip code.
Dr. Miller, I appreciate all of that and everything that you are doing. I would just encourage you to continue to be proactive in your outreach to our veterans as they're going through these challenges. So thank you, and thank you, Dr. Matthews, as well. Mr. Chairman, I'll yield back.
Well, thank you, Chairman Levin. I now recognize Dr. Murphy for 5 minutes.
Thank you, Mr. Chairman, members of the committee, and I want to thank the guests especially today for testifying. You know, as a practicing physician of 30 years, I'm terribly alarmed at the continued high rate of suicide that affects our veterans. I recently received the latest DoD statistics on total suicides for the active component, reserve component, and the National Guard for the calendar 2020. They're very alarming. I think everybody on this committee knows that. They know the suicide rates are up in all of these areas. And Mr. Chairman, I request that to enter this data into the hearing record.
Without objection, so ordered.
As we all know, studies have shown that post-traumatic stress disorder and traumatic brain injury could play a major factor in veteran deaths by suicide. A 2015 study showed that as many as 500,000 veterans who fought in Iraq and Afghanistan were diagnosed with PTSD. Most recent reports have indicated as many as 850,000 veterans have returned since 2001 with PTS or TBI injuries. Although these brave service members may have survived the terror of battle, all too often they don't survive the torment of their own injuries, memories, thoughts at home, and tragically take their own lives. Even those veterans who don't fall victim to their own combat wounds and experiences must still cope with reliving their injuries from service abroad. This oftentimes has a tremendous destructive effect on relationship with spouses, children, family, friends, and coworkers. Unfortunately, we are faced with a regrettable reality. There isn't a cure in the government's current arsenal for PTSD or TBI, which needs to be expanded, in my opinion, to include therapy, something called hyperbaric oxygen therapy, that I have worked with for over 5 years. As a physician, I've found that HBOT has been successful in treating many veterans where no other source of treatment was rendering good results, and suffering from these combat wounds, especially the debilitating symptoms caused by the impact of IEDs on the brain. HBOT is conducted by placing a patient in a pressurized chamber while breathing pure oxygen. By delivering pure oxygen under pressure, their blood levels for oxygen effectively deliver greater levels to help heal vital organs, including the brain. I've used hyperbaric oxygen therapy myself for over 30 years for the treatment of wounds. And I believe that these wounds to the brain are something worthy of investigating hyperbaric oxygen therapy. Peer-reviewed double-blind studies have confirmed the effectiveness of treating HBOT and treating PTSD and TBI. The majority of combat veterans who have used this therapy have helped it restore their executive function and feeling of well-being. Perhaps most important is the return of hope that they had lost, that is responsible for the elimination of the suicidal ideation. I'm not here to infer that HBOT will help everyone with TBI or PTSD, but the research shows that it does help a statistically significant population suffering from injuries to the brain that cause acute or chronic inflammatory indications and where other treatments simply do not help. Our veterans who have valiantly served our country and sacrificed so much deserve every remedy possible to reduce the suffering caused by combat. And I believe that every veteran, if needed, should be afforded the opportunity to give hyperbaric oxygen therapy to them. That's why I've introduced the Veterans National Traumatic Brain Injury Act, HR 1014. If passed, my legislation would direct the Secretary of the VA to create a pilot program for veterans suffering for TBI or PTSD funded by interests of VSOs. I encourage committee members to become a co-sponsor in this important legislation if they're not already. It's already bipartisan, and we're working with Senator Tuberville on the other side. He has submitted similar legislation in the Senate, and the bill is actively endorsed by the Fleet Reserve Association and Military Veterans Advocacy. While I've served in the House of Representatives, I provided this therapy also for folks in North Carolina where I serve. The 3rd District in North Carolina has over 89,000 veterans, and I'm working to make this potentially life-saving therapy available to all veterans. It's Congress's duty to pursue this option and restore hope for each and every warfighter so that we can start to see a reverse trend of these suicides. The background references of this study and many others, I would ask, Mr. Chairman, that we place this into the record also.
Without objection, so ordered.
All right, Mr. Chairman, I guess have 1 minute. If I would just ask one question to our committee members, that where do they think, what is their particular opinion? It's not new to them. Where do they believe that use of off-label HBOT is available to our veterans?
I'll allow 30 seconds.
Thank you, sir.
Dr. Brenner, I'm not sure if you're able to speak to any research that's been done in this area. I do know we do have some partnerships. We've been exploring this therapy. So thank you for the question.
Yeah, I've been quite involved with research in this area, and I think, we continue to want to provide the best care with the best evidence, and that I think we do have evidence-based treatments for PTSD and for TBI, and we want to continue to reduce symptoms and then use the best science to explore new interventions. And the findings so far have been mixed around HBOT, though I know VA is still working diligently to try to provide HBOT to veterans and explore different ways that it may be used as part of a whole toolbox of interventions for veterans.
All right. Thank you. Thank you, Dr. Murphy. I now recognize Representative Pappas, who chairs our Oversight Investigation Subcommittee. Chairman Pappas.
Well, thank you, Chairman Takano, for recognizing me. And I want to thank Ranking Member Bost as well for holding this session, and to the panelists for their work and their commitment to this issue. We know one veteran suicide is too many, but we continue to see a crisis. And it's been interesting to hear about some of the latest legislative efforts, how those are helping to move us in the right direction, but we know that barriers continue to exist to access care and services and supports at VA. And so I want to zero in on one particular group that does experience barriers to get the help that they need and the support that they have earned through their service, and that's the LGBTQ plus community. Dr. Matthews, maybe I could turn to you. On Monday, we marked 10 years since the Don't Ask, Don't Tell policy was repealed. Estimates say that more than 13,000 service members were discharged under this policy, many receiving other than honorable discharges or entry-level separations. So it's clear across the board that those who are connected to services, supports, to care at VA have lower risk for suicide. And as we kind of continue to contend with the legacy of Don't Ask, Don't Tell, I'm wondering if you could offer some comments on the directive that was issued by VA on Monday, which seeks to remove this barrier. There are some startling statistics that I've seen about LGBTQ plus veterans, people who were not able to serve openly in the military, experiencing suicide at a much higher rate. 15% of all LGBTQ plus veterans attempt suicide, according to one study, compared to less than 1% for the entire veteran population. I've got legislation I've introduced on this topic, which reflects the priorities that were outlined in the directive. But I'm wondering if you could reflect on the experience of this particular group, what VA needs to continue to do to make sure that we're removing barriers, and whether legislation will be needed to help support the direction that the administration wants to move in.
I'm so glad, sir, that for this question, just because you are hitting the nail on the head as far as really a targeted population that we need to bring some attention to. Our directive really was seeking to emphasize our current benefits policy, that this sort of exclusion is unacceptable. We really are charging our adjudicators to assure that any separations due to sexual orientation, gender identity, or even HIV status are classified as eligible. That is affirming our policy. We're also implementing a second look policy so that we can actually assure that any veterans that might have not been provided benefits are actually having their actions reconsider. So there's increased oversight and guidance through this directive. We firmly agree with ensuring that all of our LGBTQ plus veterans are receiving the services that they need. Of course, you're aware that we're also moving forward with gender affirming surgery coverage as a benefit, which was prior excluded as well too. So we're actively looking to assure that this population of veterans receives the services that they need.
Well, thank you for that. And I'm wondering if you'll commit to working with my subcommittee, with my office on the SERV Act and other legislation that is going to be needed to make permanent the expanded access to benefits and services for LGBTQ plus veterans.
Definitely, sir. VA is committed.
Well, thanks for that. In the remaining time that I have, I wanted to also ask about VA police. This has been an issue that this committee has looked at. The Compact Act included requirements for improved training for VA police to ensure appropriate response to mental health incidents at our hospitals involving those who are in crisis. As we know, VA police are often the first on the scene during one of these incidents. So I understand that each facility's police force is required to have a new curriculum as part of this annual refresher training, and that this curriculum will be developed in partnership with law enforcement training organizations and the facility's own VA mental health staff. So I'm wondering if you can tell us how far along VA hospital police forces are in implementing this requirement.
So this is so important, and actually all VA police officers do receive suicide training at, of course, initiation as a requirement of their training, but also annually thereafter. So this is really affirming for us, and we're recommitting and trying to establish stronger community partnerships so that there's even a local really contingent there to assure that our crisis intervention concepts are further engaged. This is about partnership. This is about training. This is about comfort level. So it's been a bit slower with expanding those partnerships, unfortunately, due to COVID restrictions. That's unfortunately been the case, but that in no way takes away from the fact that this training is in place and we are reiterating it every moment possible.
Well, thanks. My time's up, but maybe we can connect again about the implementation of this and how it's going moving forward. With that, I yield back, Mr. Chair.
Thank you, Chairman Pappas. I now recognize Representative Miller Meeks for 5 minutes.
Thank you, Chair Takano. I greatly appreciate it, and I appreciate this testimony and hearing. Dr. Matthews, I know that all of us were thrilled to learn that 399 fewer veterans died by suicide in 2019 compared to 2018. That was much needed progress after many years of stagnation. What specifically do you think led to that improvement, and how can it be replicated moving forward? And do you also have data and information on what conflict or war, times of service, and the age range for the majority of suicide attempts that occur?
Ma'am, if you don't mind, I'm going to defer to Dr. Miller. I don't want to speculate on causes. Do we have any information as to how those numbers decreased, Dr. Miller?
I think that, as we've mentioned, the 2019 data reflects unprecedented levels of progress. That said, again, as we've all said, within the context of the critical number is 0 versus 1, and 1 is too high. With that in mind, I think what we learned thus far from the data is 2019 represented the full start, if you will, of SP 2.0 and our public health approach, the implementation of a clinically based plan and a community-based plan. It also represented the initiation of what we call SP Now, which was designed to focus on 5 target areas where we believed if we made as a team across the VA significant, meaningful changes, we would lower the suicide rate by 7%. And that's exactly what we saw occur within that. So I think it's an affirmation of the public health approach that espouses the importance of data, following good data, and building strategy, policy, and interventions that are based on a public health approach, combining clinical and community emphasis. What do we know in terms of the numbers and risk? We know that the highest count for suicide in veterans occurs in the age group 55 and older. We know that the highest rate occurs in individuals age 18 to 34. In both age groups, white males are the predominant highest risk, and firearms are the most significantly employed lethal means. Therefore, that's where our firearm lethal means safety campaign comes in, that is addressing both age groups and demographics within the campaign.
All right, thank you, Dr. Miller. And the reason for my question was because the veterans that I encounter, and I'm a 24-year military veteran, the withdrawal from Afghanistan has been extraordinarily problematic for them and has led to increased mental health issues. So Dr. Matthews, on our second panel, the Wounded Warrior Project and Mr. Armadeus will testify about the availability of substance use treatment in conjunction with inpatient mental health treatment and how it appears that the VA does not combine these treatments or have a comorbidity treatment plan. If that's the case, what can the VA do to provide greater access to these programs? And I have very limited time, so if you could be brief, I'd appreciate it.
Yeah, I'll have to defer to Dr. Miller again.
Okay, that's all right. Mr. Miller, thank you. Mr. Armadeus, what lessons do you think that the VA could learn from the success of Operation Resiliency?
The successes with Operation Resiliency, there's many. I've personally been privy to one myself with Bravo Company 2508 Parachute Infantry Regiment, and I've seen firsthand the impact that it has on the overall population. There's no bond for it.
Excuse me, Mr. Amadeus.
Yes, sir.
You'll be testifying and answering questions on the second panel.
Okay.
Sorry, Dr. Miller Meeks, we're only doing questions.
All right. Thank you very much, Chair Takano. I yield back my time.
Thank you. I now recognize Representative Mervan, who chairs our technology subcommittee, technology modernization subcommittee. Representative Mervan, you're recognized for 5 minutes.
Thank you, Chairman Takano. Dr. Matthews, as chairman of the subcommittee on technology and modernization, I'm eager to use this hearing to gain a better understanding of the ways which the electronic health record modernization program may be leveraged to improve the VA's suicide prevention efforts. Do you believe that the EHRM program will assist clinicians in preventing suicides among their patients? And additionally, we've talked several times about the function of the suicide risk notification flags and VA and Cerner's challenges to get them working properly. And I have appreciated your forthrightness in those conversations. What is the current status of suicide risk flags in Cerner? And can you assure me that they are now fully functional and that all appropriate personnel can see them?
Yes, Sarah, thank you for the question. And you're right, it's a critical connection, but really our ability as teams, as care teams to prevent suicide is not hinging on an electronic medical record. That's a tool, right? And so those flags, those tools are quite critical. They are in place. There were some initial I would call them glitches in the programming that have since been clarified, that have been cleaned up. The user roles, particularly the suicide prevention coordinator, have also been more fully defined so that they have access to different parts of the record. If you remember, Cerner has very specific user roles. So yes, that's been clarified. It's a critical tool, but of course the true action that's taken is through our care team, and the staff there at Mann Grant staff were the ones that caught these issues and therefore allowed us to make the improvements that were needed from that baseline go live. So I have full security in the fact that we'll be able to continue with the strong work that we do as care teams with the new system as well.
Thank you, Dr. Matthews. Secondly, Dr. Miller, the 2008 National Strategy for Preventing Veteran Suicide contained the important insight that not all veterans have the same risk for suicide. Specifically, the strategy identified women veterans as a subgroup potential higher risk for suicide behaviors. Are these specific suicide prevention resources available to women veteran survivors of military sexual trauma, including during the MST claims process? If so, what are these interventions and have they been effective? Dr. Miller,
Dr.
you
Miller,
just
you're
have
on
to
mute.
mute.
You're on mute. Try again, Mr. Miller.
It was with regard to the 2018 national report you mentioned, and it was specific to what population, sir?
Are there specific suicide prevention resources available to women veteran survivors of military sexual trauma, including during the MST claims process? If so, what are these interventions and have they been effective?
Yes, there are specific interventions and programs that are available for women veterans, particularly women veterans who have experienced or are engaged in the MST evaluation process. I believe that you're seeing from our 2019 data solid indications that the programming that's been engaged by the VA for women veterans is heading in a positive direction, and that's indicated by the 13% reduction in women veteran suicide rate in 2019. That took it to a level that it has not been at since 2002.
Can I just jump in there too, Dr. Miller? Just want to highlight that we've talked a lot about populations and we've talked a lot about context. And I think really beginning to understand the context of these women's lives. Many of these women actually have experienced interpersonal violence before they come in the military, may experience interpersonal violence after the military. And how do we create treatment settings, resources, materials that will fit for them so that they can benefit from our evidence-based treatments that we have in the VA.
Thank you, Ms. Brenner. And thank you, Mr. Miller, and I yield back my time.
Thank you, Chairman Mervan. I now recognize Representative Rosendale for 5 minutes. Representative.
Thank you, Mr. Chair. Good to be with everybody today. And thank you all for participating in this critically important issue. I attended a veteran suicide prevention program about a week ago in Bozeman, Montana, and it included a presentation from the Overwatch project that featured a bunch of really valuable, what I consider valuable online resources where we as the general public could access that, veterans could access that, and so that we all could do our part in supporting veterans and quite frankly, how they could help each other as well. And while I really recognize that this is a real problem, the access to firearms and the amount of times that veterans are obviously using firearms to take their own lives, and that we need to put time and distance between veterans and their guns during a crisis period. It sounds like there's like a 10-minute period between when they decide that they're going to take their life and they actually do it. And if we can get time and distance between them and their firearms, then that's going to be a good thing. What I also recognize is that mandated removal or restrictions on veterans' firearms who sought help would be very counterproductive and quite frankly would be completely unacceptable to many members of this committee. And so while Chairman Takano was speaking with you, Dr. Miller, it sounded like you were getting close to discussing your recommendations with him about what you would recommend. And I wanted to hear those recommendations to make sure where we were headed in order to address this problem without infringing on the rights of our veterans.
So I think that there's two really important words to ensure that I'm communicating the distinction between and where we land with regard to firearms and lethal means safety. The two words are restriction and safety. We are not gearing any campaign or messaging towards restriction. We are gearing our messaging and campaign towards safety. Safety in this context is defined exactly as you said, as time and space between person, firearm, and ammunition, 3 parts of the triangle, during critical points in time that may be described as dark or crisis. So that's why you'll see in our lethal means safety campaign that it puts together depictions of veterans experiencing particular risk factors. And in that context, with access to a firearm, engaging time and space mechanisms. And you're 100% correct that that 60-minute window is critically important. And within that 60-minute window, 10 to 20 minutes can be life-saving in and of itself. So that's our recommendation and our point of emphasis, sir.
Okay, I appreciate that. That makes me feel a lot more comfortable because again, I just can't stress enough that the mandated restrictions or control over veterans' firearms would be very problematic. Dr. Matthews, the crisis in Afghanistan has led to significant increases in the utilization of the Veterans Crisis Line over the last month. Well, how's the VCL adapting to those increases, ensuring that the veterans continue to be well and promptly served?
Great question, sir. Just to reiterate, we are definitely assuring that our staff has appropriate resources about the withdrawal, knowing how to interact with veterans. We're making sure that that staff is adequately supported through different wellness programs. We're anticipating the increased volume, so making sure that we're appropriately staffing shifts or having backup plans in order to take care of that volume. Every call must be answered, and every call, text message, or even chat must receive the attention that it needs. And of course, we're monitoring appropriately so that we can make sure that we continue this effort. But the VCL has really, truly responded appropriately. Dr. Kearney and team are really providing that support that's necessary.
Excellent. Thank you so much. Mr. Chair, I'm right down to it, so I would yield back. Thank you very much.
Thank you, Mr. Rosendale. I do appreciate your very responsible comments and understanding of the time and space campaign by the VA, and I think I appreciate that language that we can come together on a very sensitive topic, so I just want to express my appreciation for that. I do want to now recognize Representative Sablon, who is communicating to us probably at a very ungodly hour in a very godly place on the planet. Representative Sablon, 5 minutes.
Oh, thank you. Thank you, Chairman Takano and Ranking Member Boss for holding this important hearing on veteran suicide prevention. I also want to thank the witnesses who are with us today. Chairman Takano, it is so good to be here in DC and to join all of you in a time zone, in the same time zone. Otherwise, we would have started the hearing at midnight for me, but it's 11 in the morning here. Because we usually bring out the shortcomings of the Veterans Administration, I want to bring out a happy story, a story with a rather happy ending. There was a soldier who grew up across the street from our family home and who got out of the service in 2011, if I have it correctly. And I know because we try to help the soldier and his mother in the first 2 years of his after he got out of the service. He was truly a broken man. But last week he's come home to retire. But last week he came to visit me, and I was just so happy with who I was talking to face, that sure, we discussed the many issues he went through, having just to recover. And the fact that it took him several years to come home because he can't get the services he needs at home. But this is a soldier with 5 Purple Hearts, 3 Bronze Star with Valor, and so very highly decorated infantryman from Fort Drum, the Mountain Division. Dr. Matthews, let me ask, since, generally veterans in my district do not get access to the same services and benefits the VA offers across the nation, across congressional, I would very much like to know whether veterans in the Northern Marianas are benefiting from the suicide prevention initiative you outlined in your testimony.
Unfortunately, sir, I can't speak directly to veterans there. I can definitely take that for the record to get you some specific information. They do, of course, have access to the VCL and can readily use a lot of our online resources as well as chat functions if indeed that's necessary. But I think unless Dr. Miller, you have some specific data around the Mariana Islands, I think we'll have to get back to you with some data there.
I'll just add that a focus of our governor's challenge for this upcoming fiscal year is U.S. territories. And we're looking forward to the opportunity to learn ways that we can improve access to services for veterans in U.S. territories and further the suicide prevention mission in those areas. So looking forward to FY22, sir.
All right, thank you. And so again, and maybe this is something you will be able to look at, and without breaching confidentiality, of course, but can you also look at, since I don't think you can tell me today, can you also look at how many veterans in the Northern Marianas have been able to use support offered by the Suicide Prevention 2.0 initiative, the Suicide Prevention Now initiative, and of course the Prevents program, and to look at what is the VA doing to make sure veterans know about the programs and how this congressional office could help. I look forward to you looking at those and providing us with information. Again, Dr. Matthews, you stated in your testimony that most veterans who die by suicide are not receiving VA health care at the time of their death. As I mentioned, there are any number of veterans VA healthcare programs and services that are simply not available in the Marianas for veterans. And coming from a population of 55,000, one death is a death in the community by suicide is really makes a profound impact on our community. And I know that there may be more, but I know that we have had 2 deaths by suicide. So if you, of course, my plea always is if you would agree that providing veterans with the same level of care available in most of the United States so that it would reduce the risk of suicide. And finally, in February of this year, my office was briefed on the VA's plan to hire a primary care doctor or an advanced practitioner who would also travel to Tinian and Rota to see veterans and to build up and strengthen telehealth services in those areas. So right now we do finally after years, we have a licensed social worker. I would like to know whether this social worker is able to go to Tinian and Rota to meet with veterans and get a primary care provider, a doctor to visit the veterans in these islands as well.
Sir, I'll get some information back about that social worker. I'm glad to hear that person is there. I just am not familiar with what sort of interaction they're having, but we can definitely take that for the record.
Thank you. My time's expired. Yeah, go ahead. No, please.
Yeah, can I jump in also? Because I think there's a new exciting program that we are just getting started with, trying to understand, individuals living in different parts in the territories to understand better how we can provide care to people, Pacific Islanders, Asian American veterans, understanding the context in which they live. And we'll be doing key informant interviews and looking at geospatial analyses, looking at different epi data so that we can do even better to understand kind of individual drivers, contextual drivers that really do contribute to risk in your community and other people's communities. So I hope you stay tuned for, I think, this new important program that we are just getting underway.
Right. And thank you again. You guys really do some wonderful work. And like this soldier who's returned home to retire, right now we're helping him get his all of his records moved to the Pacific Islands Medical Center. So Chairman, I am way over time. I appreciate your patience.
Yes, you are,
Thank you.
Representative. Yes, you are. But if it's any, Representative, I just want you to know that in the mental health package, I am planning to include a bill to get the Marianas a vet center. So.
Thank you. Thank you, Mr. Chairman, for your always support. I appreciate it.
Thank you.
Thank you.
All right. Representative Ellsey, you are recognized and welcome to your first full committee hearing.
Thank you, Mr. Chairman. Thank you, panelists. It's a pleasure to be here, and especially for this very important topic. I don't intend to use 5 minutes, nor do I have any questions, but I'd like to make a comment as a 20-year Navy veteran who retired in 2012. First of all, you and the VHA are the 911 for veterans everywhere. You have a thankless, stressful, and very difficult job to deal with the end result of how veterans handle their time in the military. And for every veteran, whether they see combat or not, any deployments, they come back a little bit different, and you are on the receiving end of that. And I'd like to thank you for all that your hard work. I'd also like to point out that those who are on the Veterans Care Line have a stressful job indeed. That is like being a dispatcher for police departments, except you're trying to save a life yourself. And I hope that those folks are adequately taken care of with that stressful job that they have too. You know, we have the most well-trained military on the planet. And from the time you take your oath and you're inducted into the military, you are trained in everything that you do, from how to fold a t-shirt, to how to eat, to how to fire your weapon. When we take people in, generally, since it's an all-volunteer force, we're asking the best of us, the people who walk the old ladies across the street, who go to church, who care for their country, to do the worst thing a human being can do. And that's deliver ordnance on target, usually resulting in the loss of life. That's a very stressful thing, and every veteran deals with it differently. No matter how long you serve, whether it's 2 years, 5 years, or 20 years, the transition to being a veteran is non-existent. The military does a great job of training us up to do everything that we need to do. And then we'll probably have a 2-day transition assistance program class. And they say, thank you very much for your service. Good luck, Godspeed. We're all counting on you. That door over there is the VA, and go find it. That's a daunting task for people who've been taken care of, where the military becomes their family for so long, and they are left without any training. So we have the best trained military on the planet, but the transition from service member to veteran does not exist. So you don't have very well-trained veterans. And I'd like to see greater collaboration in the future between the Department of Defense before a service member is released, both on health checkups of mental, psychological, and health-wise, so that they have every tool in their toolkit necessary to make a transition to a life that's now foreign to them, and that is civilian life. So I appreciate everything that you do. God bless you all for what you do. It's a privilege to be on here. Mr. Chairman, thanks for recognizing me, and I yield back my time.
Well, thank you for that, Representative Ellsey. And I invite you to take a look at the bills that we have so far included in the mental health package. They address many of the things that you just talked about. And of course, I welcome the minority to also continue to look at what they can contribute to the mental health package and suicide prevention bill that we're trying to put forward. So thank you very much. I agree with much of what, actually, I don't think I disagree with anything you've said with regard to the transition, ways we can improve it. There has been tremendous bipartisan cooperation in terms of the topics you've addressed, so thank you. Representative Underwood, I now recognize you for 5 minutes.
Well, thank you, Mr. Chairman. I join my colleagues on this committee and Americans across the country in grieving the deaths of the U.S. service members who were killed during the August 26th terror attack in Kabul. The VA has responded swiftly to the surge in demand for mental health and crisis resources, and I urge the department to continue to take every available step to ensure that veterans suffering from new or worsened mental health conditions have access to the care and to the support that they need. Now, there have been reports of significant increase increases in outreach to the Veterans Crisis Line in recent weeks, including a 98% increase in text messages to the hotline between August 14th and August 29th. Now, the VA must also continue to expand evidence-based practices to prevent veteran suicide, including lethal means safety training. Given the proven effectiveness of lethal means safety training in reducing suicide rates, the VA requires all VHA clinical healthcare providers to take the department's lethal means safety training. As a result of this requirement, compliance is already above 90% among newly mandated VHA providers. However, the lethal means safety training course remains optional for other VA staff who regularly interact with veterans, as well as community providers and caregivers. My Lethal Means Safety Training Act would expand the required training courses to ensure that anyone who regularly interacts with veterans in their work is prepared to have a conversation that could save a veteran's life. So Dr. Miller, in response to a letter that I sent to Secretary McDonough in February, VA staff noted that only 30 community providers have completed the optional lethal means safety training course since October 2020. That's 30 providers across the country. Unacceptable. The Secretary's response further stated, quote, without a national mandate or incentive for non-VA community providers to take this course, VA will likely continue to face notable challenges advancing the mission of increasing the competency of the community and community-based healthcare providers to better identify, assess, intervene, and treat veterans at risk of suicide, end quote. Now, during the committee's hearing with Secretary McDonough in March, I asked about opportunities for the Secretary to use his own existing authorities to further expand mandatory lethal means safety trainings. And I was encouraged by his commitment to looking into this critical issue. So Dr. Miller, my question is, can you provide an update on any steps the VA has taken in the last 6 months or other actions that might be planned to expand lethal means safety trainings for VA staff, community care providers, and caregivers?
Thank you for your push and prompt on this very important issue. We share the perspective that this is critically important to suicide prevention as a whole, and as we've talked, accounts for 70% of veteran suicides with firearms alone. More broadly, with lethal means safety training, since that point in time, with the Secretary's support and at his behest, we have moved to officially integrating lethal means safety training as an agency priority goal for FY22, which includes training for community care providers who are working with veterans.
So you said a goal. What does that mean?
It means that we have put in writing that it is officially an agency goal to increase and enhance training, not just for VA and VHA providers and teams, but for community care providers as well. The first step of that is to take a look at ways that we can create a preferred provider system and network where community care providers who are working with veterans are incentivized to engage in the same training that VHA clinicians are engaged in turn becoming then a preferred provider within the network for veterans based upon their increased awareness and acumen with lethal means safety.
And is this the only criteria to obtain the preferred provider status?
This is the only criteria that I am aware of because I am in on the discussions with regard to lethal means safety. I don't know if there are discussions outside of lethal means safety training and applied to preferred provider.
And as we close, do you know if this goal and the requirements will be complete by September 30th, which would be the end of this current fiscal year ahead of October 1st, the beginning of fiscal 22?
they would be complete by the conclusion of FY22, which would be next September.
The goals would be complete. Okay. If you all could have a get back to the committee and to my office about the current status of this goal setting process and the preferred provider program, including the criteria. I think this is a little bit askew from the mandate that we are looking for to ensure that any provider who is regularly interacting with a veteran, whether in the community or within the VA, is prepared to have a life-saving conversation. Thank you all to all the witnesses for your time. Thank you, Mr. Chairman, for your indulgence. I yield back.
Well, thank you, Representative Underwood. You're always well prepared for our hearings and holding to account our administration folks. So thank you. Representative Allred, you are recognized for 5 minutes.
Okay, thank you, Mr. Chairman, and thank you everyone for your testimony and to the researchers for sharing your research. Obviously, preventing suicide and ensuring access to resources in mental health is one of our top goals, and we're committed to, on this committee, to working with y'all to do that. I wanted to ask about the use of MDMA and psychedelic drugs to combat PTS, and where the VA is in terms of studying this. There's a recent New York Times article discussing a study of 90 people that seem to show some pretty good results from this. And in my conversations with some of my constituents, veterans, some of whom have sought this treatment out even outside of the country, anecdotally, they found it to be effective for them. So I wanted to ask whether or not this is something the VA is looking into, whether or not we have anything along these lines, and whether, and for not, if we don't, whether we're considering it.
Dr. Brenner.
Yeah, happy to respond. Thank you, Congressman, for the question. We're also watching very, very closely, both clinicians, researchers, and the Office of Research is watching very closely. Not only that, we do have researchers that are connected to the VA that are working on some of these projects with their affiliates. And so we are tracking very closely. There are currently some trials underway, as you already highlighted, and we're eagerly anticipating the results from those well-designed trials. And once we are able to see the results from those well-designed trials, then we will be able to kind of begin to think about what would be next steps in terms of any modifications necessary or what next steps within VA would be. But along with you, we will continue to watch closely.
So would you need any additional authorizations from the Congress to pursue that? Or is that something that you could do if those studies prove to be efficacious, that you could do it on your own authority?
This is a complicated issue because of the specific intervention, and I will take it for the record, but I know we're watching closely and we will get back with you, particularly once we find out what the results of the trial are.
Okay. Okay, so just generally the approach here is to see how these outside trials function. Because obviously I know one of your missions is research, and I know we have do some of the best research in the world, in the VA. But in this case, the approach would be to see how the outside trials, what their results are, and then proceed from there. Is that the understanding? Okay.
Yes, that's correct. And the trials, I'm very happy to say we looked closely at them and they're well designed. And I think, trying to kind of benefit from the work that's being done and then using that resource to help us guide next steps. Okay.
Because obviously this is your area of expertise and not mine, but anecdotally, some positive results, and also from these early trials, it seems to be, could be a real breakthrough. And so I hope that we'll continue to pursue that. If my office can help you with anything there, please let us know. I wanted to really quickly turn, Dr. Matthews, to your testimony regarding COVID, and a study that found that veterans with COVID were more than twice as likely to report suicidal ideation. And want to know, did the study identify causes for this, and does VA have any indicators of why that is?
Sir, I'm not familiar of unfortunately any information that we have as of yet. I think I think to purely conjecture. I think everything that kind of comes along with the pandemic, including probably a lot of the risk factors of how the veterans actually got COVID in the first place, are probably just as indicative of causing increasing mental health concerns. So I think we need to get back to you about any real evidence. I'm purely speculating at this point, but it's something we're definitely tracking. Unless Dr. Miller, you know of something more, but I haven't necessarily seen any evidence of the exact reasons why.
So there was a published study, JAMA Psychiatry, probably 3 or 4 weeks ago. It hit the presses and it was specific to the veteran population and COVID. And it found that overall suicide behaviors, as evidenced by suicide ideation, had not increased in the veteran population during COVID, except for those veterans who manifested what we might call pre-existent risk factors, in particular substance use disorders, social disconnection, and some other mental health issues or disorders.
Okay. Well, thank you. I think should you find that this is an ongoing problem, I think we should consider tying COVID testing and diagnosis to our mental health resources immediately. If that's not something we're already doing. So
we are doing that. Yep.
Okay.
COVID diagnosis plus high risk flag come together and an outreach kicks in immediately through the local facility.
Okay, great. Well, thank you all for the work you do, and I'll yield back, Mr. Chairman.
Thank you, Representative Allred. Representative Trone, I recognize you for 5 minutes.
Great. Thank you, Chairman Takano and Ranking Member Boss for this hearing today. As the chairman and the ranking member know, my office focuses very heavily on addiction and mental health. So this discussion today is really meaningful, and really appreciate the chairman and the ranking member bringing this forward. Last Monday, I toured Maryland's 6th District with Secretary McDonough, and we stopped by Gaithersburg, our CBOC, and had a roundtable discussion on mental health, suicide, and substance use disorder. During the roundtable, Dr. Neptune, the DC VA mental health expert, shared with us what she tells a patient that is skeptical about asking for help. She says, quote, "You're doing something wise, not weak." I think that's especially meaningful because that mental health stigma still exists so much in our community, especially with our vets. So we're lucky to have folks like Dr. Neptune combating stigma. The committee recently passed the bill to provide $18 billion for VA physical human infrastructure. More importantly, or most importantly for me, $375 million in residency slots, which will help the VA train and retain excellent mental health professionals like Dr. Neptune. So to better understand the population of veterans seeking health care, Dr. Matthews, if you could for a second, if we compare the population of veterans seeking mental health today versus our vets 10 years ago, what's different? The availability of services, talk about that, and the acuity of conditions also, or maybe something else.
I think we have a great deal of difference, both in how veterans are seeking out services, as well as our awareness of how to offer those services, and most importantly, screen and evaluate those services. Matt, do you want to go into greater detail there, a 10-year timeframe?
Sure. We have, I think, a significant difference 10 years ago to now with regard to access. We now are able to offer same-day access to mental health care as well as primary care at every local VA facility. And by the way, when we were discussing the question of what should a veteran ask for, have them get on the phone and call their local facility and say, "I'm interested in same-day access for mental health at this facility. Tell me what I need to do, where I need to go, and how we need to kick that in." And they should have an SOP and an answer for that. And if they don't, we want to be the first to know that that is or has occurred. So you're also going to see increased access to the Veterans Crisis Line. 10 years ago versus now, you're going to see text and chat, and we were phone-based before. You're going to see press 7 on the phone to any forward-facing VHA number. That wasn't in place with the Veterans Crisis Line prior. Finally, you're going to see increased access options that aren't just limited to geographic related variables. For example, if I am interested in an evidence-based treatment for suicide prevention, but I am in Saginaw, Michigan, and the Saginaw VA is not able to provide that, I can connect to the VISN 10 resources for that and receive those services through my phone, through my computer. So I think that those are some notable examples.
I would also highlight that VA has taken on the largest in the US for sure, and maybe the largest known universal screening program in a healthcare system for suicide risk. And we have been able to screen millions of veterans for suicide, and doing this in a universal manner, decreases stigma, we ask everybody, and also really identifies individuals who may not be maybe prepared to talk about it unless they're asked. And I think this new practice that we've been rolling out in the VA, and we're rolling it out, studying it, and looking at outcomes. I've been on several calls with other agencies, other healthcare systems, and this is really being seen as something that could be adopted by other systems. So I think that is a completely different way of doing business.
Well, thank you, Mr. Trone. Your time has expired. Mr. Trone, did you have? Well, Mr. Trone,
Yeah.
No,
I'm fine. I yield back, Mr. Chairman.
Okay, thank you. Ms. Capter, I recognize you for 5 minutes.
Thank you, Mr. Chairman, for this excellent hearing, and also Ranking Member Trone and all of the members, obviously, who participated fully. And we want to thank those who are dedicating their lives to healthcare for our veterans. Thank you all so much. As we can tell today, all of us are very concerned about the brain conditions that onset during or as a result of military service. And Ms. Brenner, I was very happy to hear you talk about the recruitment phase, because we need to understand who is coming into the military with conditions that actually were created before they came to the military. We know PTS onsets faster in those who have have experienced pre-enlistment violence. That is certainly true across the country. One of my goals, top goals, is to improve the number of healthcare providers, doctors, advanced practice nurses who specialize in the psychiatric and neuropsychiatric arena. And that is a long battle, but one that I would welcome all your recommendations for as we move this particular bill forward. But I am interested in improving as well the diagnostic capabilities to identify brain-related functions, particularly through high-frequency imaging, to pinpoint where underlying conditions present and maybe we'd have markers in the biochemical interaction in the central nervous system of brain function, where we could predict better what can happen. And to that end, I wanted to just mention this to you. I've worked as a member of the Defense Committee for a number of years to work with the Ohio National Guard and Case Western University in Ohio for our enlistees to provide DNA samples, particularly to understand why did some people get PTS and others not. I'm just informing you of the results of that study, and that all of the DNA samples are now located at the Veterans Education and Research Association of Michigan at the University of Michigan. They call it VRAM, VERAM. I believe that the data sets have not been fully probed. And I think more research can be done there. And we've spent literally millions of dollars along with the Ohio Guard trying to understand these conditions. So I just wanted to let you know that those exist. And I think we should continue the high science. And the VA's budget is much smaller than the Department of Defense or the Department of Energy, for example, in terms of developing a research protocol for high frequency imaging and for the careful assessment of biochemical imbalances of the central nervous system that result in mood disorders. I'm just one member out here trying to help, but I really do think we can make scientific progress in our lifetime because of the existence of supercomputing now. And I really would love to talk to you more, along with my colleagues, our chairman, our ranking member, about some research protocols that we could work across government on that might be able to just move us into this era where we could understand so much better how to treat, first how to diagnose, and then how to treat these conditions, the stress receptors in the brain and so forth. I think there's a lot there we could do together. So I just wanted to put that on the record. If you want to give any reaction, you certainly can. But as others have stated, we are so grateful for your service to those who have served the cause of liberty around the world and in our country. Thank you.
Great. There's no response. Thank you, Representative Capter, for sharing that information. And I know of your passion for the advanced science and the research that's going on in this area.
Thank you, Mr. Chairman, very much. And I hope that those who didn't have any reaction at all, I hope that we might be able to have a further conversation on this and how to move additional research forward in this very important arena of understanding how stress and certain concussions and brain conditions contribute to these illnesses. And so we're not just treating symptoms, but we're actually going right to where the pre-markers exist in the human brain.
I just want to assure you that my passion for this matches your passion for this, and I am excited to hear more. So I want you to know that I hear you and am.
Thank you.
I'm with you.
Thank you.
Thank you, Ms. Brenner. And also know that we have a Million Veterans Project that is sequencing the genome, the genomic sequencing that's going on at the hundreds of thousands of sample level in our Boston repository. So some of the work can be done with that database as well. I see that we have Mr. Cawthorn has joined us. Mr. Cawthorn, you're recognized for 5 minutes.
Thank you, Chairman Takano, and as always, Ranking Member Bosch, thank you very much for your leadership. I'm pretty sure all of us on this committee at some point have probably done the challenge where you do 23 to 25 push-ups every single day, really symbolizing the fact that we are losing 23 to 25, and I believe even more now, veterans every single day. This is something that I take very seriously. And when you're doing that push-up challenge and you're going through it, it's easy to just kind of say, okay, I did my 23, I'm done, you move on. But when you really sit down and think about it, when you sit back to really believe that these heroes who wear bulletproof vests, who carry M4s, who go and fight for our freedoms abroad to make sure that no attacks ever happen on our homeland, who defend liberty, are committing suicide once they come home, that the idea that they are at a higher chance of dying once they return home than really many of them are in active battle zones, it really hits home with you. It truly makes you feel that our country is failing them, that us as a VA are conducting an abject failure to allow this many service members' mental illnesses go unanswered. And I know that many of us are doing things to take care of this, but I do have some questions for our esteemed panel here. Ms. Hetrick, what have you heard about the catastrophic effects that this Afghanistan withdrawal has had on mental health?
Mr. Cawthorn, that Ms. Hetrick is part of the next panel. We are limited to questions to our VA representatives on this panel. So
my apologies. I apologize, sir. I will hold my remarks for the next panel. Then my apologies. With that, I yield back.
All right, thank you. Mr. Gallego, you're recognized for 5 minutes.
Thank you, Chairman. Dr. Matthews, veterans' ability to access affordable care is essential to ensuring that they receive mental health and other treatment they need. Last Congress, my bill to end co-payments for Native American veterans passed as part of the Isaacson and Roe Act. The federal government owes Native American veterans health care free out-of-pocket costs in accordance with our treaty obligations. Native veterans, of which I serve many with, also suffer a disproportionate rate of PTSD and death by suicide as compared to their fellow veterans. So it's essential that VA move quickly to remove barriers to care. As such, can you share what progress the VA has made in implementing this provision and what is the current timeline for full implementation?
Great, thank you. Yes, this provision out of the Isaacson Roe bill is actually moving forward. It's drafted and it is in the concurrence conversations now. There were some nuances, just so you're aware, about the definition of urban Indian, just because that's not necessarily a term. And so we've been working with the Indian Health Services as well as Human Health Services, as well as other tribal organizations to make sure that we get that language correct and that we're referring to the right population. But other than that, the regulation is moving forward. It unfortunately is not on time. I was told it won't make the January timeline, closer to middle of 2022 calendar year, but it is moving forward.
Okay, great. And Dr. Matthews, if you do need any more assistance on that, especially with the definition of urban area, we'd love to be helpful on that. I worked also on the Natural Resources Committee and actually do work with UIOs a lot. And I want to make sure this is fully implemented. And this is kind of a general question, whoever can answer from the VA. Earlier this year, Senator Kelly and I sent a letter to the VA in response to OIG findings that the Phoenix VA had made several critical errors in the care of a mental health patient. While the Phoenix VA has taken corrective action on the issues that occurred, we want to make sure that veterans aren't falling through the cracks nationwide. In response to that letter, the VA shared that it was in the process of designing a suicide prevention site visit pilot program to increase oversight of suicide prevention programs, prevent errors before they occur, and improve sharing of best practices. Can you share any update on that pilot program? And this is open to anybody in the VA.
Yeah, Dr. Miller, you can speak to the, yep.
Yes, happy to say that the pilot program is in motion. We have our first VISN selected for engagement in the site visit process, and we will be engaging the actual site visit within the next 30 to 45 days. The VISN leadership has concurred with the process and are looking forward to participating. It'll be within VISN 22, which includes the Phoenix VA.
Excellent. Anybody else have anything else to add? Perfect. Let me move on to then. As you know, keeping veterans stably housed is one of the most surest ways to prevent veteran suicide. In Phoenix, I'm working with organizations like US Vets and Chicago's Por La Causa and community projects to provide veterans housing and wraparound services, because we know anecdotally how hard the pandemic has really been on veterans. Does the VA have updated data on how the pandemic has impacted both veteran homelessness rates and veteran suicide rates?
Great question, sir. This is really getting to an important point about really the connection of these risk factors, risk for homelessness, risk for suicide, that homelessness prevention is suicide prevention. I unfortunately don't have data. You know, we rest a lot on our PIT counts, of course, right? And unfortunately that hasn't necessarily been updated. But what I can say is thanks to your support, we've, of course, been provided significant funding to our SSVF grantees for more non-congregate housing to keep our veterans safe and in more motels and hotels over the last year or so during the pandemic. That's much safer than kind of the shelter congregate settings. We'll continue to really also promote with our SSVF grantees that they are actually taking part in our suicide prevention efforts, so that they're actually looking for risk factors, even improving their policies about how to connect veterans back to care, and really being players, being our partners in suicide prevention strategy. So those are active really changes, updates with the support of this body that we've been able to provide during the pandemic.
Do we have, and I could take this for the record, do we have any data on how our housing efforts are helping lower the suicide rate, or even how the money is being spent anecdotally so far?
I'll have to take that for the record, just about the actual impact. I'll have to take that one for the record.
Okay. All right. Thank you, Mr. Chairman. Are you back?
Thank you, Mr. Gallego, for those absolutely amazing questions. I want to now say that the questioning for the first panel is now complete. I want to thank our VA witnesses for appearing today, and we'll now move on to our second panel. Doctors Matthews, Miller, and Brennan, you are now welcome to stay on the Zoom and listen to the testimony of our second panel witnesses, which I think will be very important for VA to hear. I'll now call up and recognize our second panel. With us, the first person I want to introduce is Ms. Tammy Bartlett, Deputy Legislative Director of the Veterans of Foreign Wars. Second, Ms. Caitlin Hetrick, Government Affairs Associate with the Iraq, and Afghanistan Veterans of America. Ms. Jennifer Silva, Chief Program Officer at the Wounded Warrior Project. Chief Bill Smith, Chairman of the National Indian Health Board. Mr. Nick Armendariz, an Army veteran. And Dr. Rajiv Ramchand, co-director of Rand Epstein Family Veterans Policy Research Institute and senior behavioral scientist with the Rand Corporation. Thank you all for being here. I'll remind our witnesses to pause 2 to 3 seconds before speaking and answering questions. Ms. Bartlett, you're recognized for 5 minutes for your testimony.
Chairman Takano, Ranking Member Bost, and members of the committee. On behalf of the men and women of the Veterans of Foreign Wars of the United States and Auxiliary, thank you for the opportunity to present how the VFW is spreading awareness for suicide prevention. Veteran suicide prevention requires a multifaceted approach. An upstream perspective can examine root causes and support protective factors before mental health reaches a breaking point. The social ecological model brings together the individuals, family and friends, and communities to create connectiveness, strengthen life and coping skills, empower purpose, and address social determinants of health to improve outcomes and reduce the risk of suicide. One of the VFW's most prominent resolutions is to end veteran suicide. The VFW has multiple programs and outreach opportunities, such as our #StillServing campaign, to engage suicide prevention awareness. I touch on these programs in my written testimony, but I will take this time to highlight a few. Whether it's in response to a worldwide pandemic or a natural disaster, VFW posts are still serving their communities by opening contactless drive-through food pantries, doing buddy checks, using technology to connect, or rallying with other veteran organizations for a common cause, thereby strengthening mental well-being and staying engaged and driving a sense of purpose. As the world watched the US troops withdraw from Afghanistan, the collapse of the Afghan government, and the return of the Taliban rule, some veterans questioned the worth of the work they had done during their deployments. Several VFW posts channeled this energy and took action to check in with each other and found ways to help those who've helped them in the past. VFW posts 2974, 1503, and 3150 in Northern Virginia collected over 5,000 items of clothing, shoes, and various hygiene products, and also raised over $7,000 to donate to local nonprofit organizations assisting Afghan refugees. The Post also collaborated with the Georgetown University Student Veterans Association, VA, and the Afghan Youth Relief Foundation on September 11th, Patriot Day and National Day of Service and Remembrance, to sort through the organized donations. From the national level to the Post level, the VFW continues to do more for veterans, to include supporting innovation in suicide prevention. VFW Post 11453 in Cheyenne, Wyoming, raises funds through the Buddy Poppy donation, and then presents that money to Grace for Two Brothers, a local nonprofit providing suicide prevention education to purchase and distribute gun locks. Vet centers are an excellent tool in VA's toolbox for veterans seeking mental health care. The VFW urges Congress to require VA to assess vet centers and expand eligibility to include certain veterans using education assistance benefits. As vet center eligibility and usage increase, we must also provide an increase in resource for this vital program. Earlier this month, VA published its 2021 National Veteran Suicide Prevention Annual Report. This report acknowledged progress, but the VFW remains concerned that we do not have the complete picture on how this change occurred. We believe that VBA has access to information that can inform decision-making on VA programs like disability compensation, GI Bill, or home loan guarantee, which are facets of critical social determinants of health. This data should be easily cross-referenced with data already in VHA and now the National Cemetery Association Administration to produce the annual suicide prevention report. The VFW has asked these questions for years, but VA has either chosen not to elevate it or does not want to share it. If VA is serious about understanding and preventing suicide, then we must demand a more thorough evaluation of all VA programs. This is why the VFW calls on Congress to direct VA to include relevant VBA data in the annual report for all VA programs and their impact on suicide, veteran suicide. Eliminating suicide among our nation's veterans will continue to be a top priority for the VFW. Veteran suicide prevention awareness is not just a VA, congressional, or veteran organization issue. It's an everyone issue. Chairman Takano and Ranking Member Boss, this concludes my testimony. I'm prepared to answer any questions you or the committee members may have. Thank you.
Thank you for your testimony, Ms. Bartlett. I now recognize Ms. Hetrick for her testimony from IAVA.
Chairman Takano, Ranking Member Bost, and distinguished members of the committee, on behalf of IAVA and our more than 425,000 members, I would like to thank you for the opportunity to testify for today's hearing on one of IAVA's top priorities for the 117th Congress, mental health care and suicide prevention. September 11th, 2021 marked 20 years since the start of the global war on terror, a war that created an entire new generation of veterans. Before this monumentous anniversary, President Biden announced that American troops would withdraw from Afghanistan by August 31st, 2021, following a previous commitment to withdraw by President Trump. This effectively ended the 2-decade-long war, and in early August, the world watched as the Taliban swiftly made their way through the country of Afghanistan and seized control. Many veterans watched as their former bases were taken over by the enemy that they selflessly fought alongside Afghan and NATO forces to defeat for 2 decades. Feelings of anger, sadness, and despair filled the hearts of our nation's veterans, service members, and families, and for some, the trigger of these events brought unexplainable pain and changed the way that they viewed the war. IAVA regularly surveys our members to gauge what issues are important to them and what needs to be improved upon to help veterans. Our most recent survey opened on September 8th, just over a week following the official withdrawal of U.S. troops from Afghanistan. The preliminary data from our survey shows that only 52% of our members feel our engagement in Afghanistan was worth it. This is a 10% decrease from how they felt in 2020. The preliminary data also shows that although 63% agreed with the need to withdraw troops, only 22% of our survey respondents approve of the way that President Biden withdrew from Afghanistan, and 86% of our respondents agreed that more should have been done to support the evacuation of Afghan allies during the withdrawal. War affects every veteran differently, and the circumstances that took place over the last month and a half have no doubt caused a lasting effect. IVA's Quick Reaction Force, a concierge program helping veterans, service members, and families navigate an often complex roadmap to quality-free services, saw an 80% increase in mental health inquiries from August 16th through the 31st, 2021, when compared to those dates in 2020. VA must continue to push out messages of support and available mental health resources for veterans during this challenging time, both within and outside of VA. Additionally, our preliminary data shows that almost 43% of survey participants have considered taking their own life following joining the military, and only 10% considered it before. 2/3 of those that participated also stated that they personally know someone that has died by suicide, and 25% stated that they are not seeking help for their service-connected mental health care injury. When it comes to top reasons that our members are not seeking care, they cite that the negative stigma around mental health care is too great, a common issue that is heard from both active duty and veterans. The issue of domestic violence has long been ignored when it comes to both occurrences within the military and following separation. A recent article following an investigation by CBS News found 100,000 incidents of domestic abuse have been reported to the military since 2015. According to data released in 2019 by DoD, incidents of spousal abuse in the military were more than twice that of the national population. IVA's preliminary survey data showed that 61% feel that domestic violence is a serious issue within the military, and approximately 32% are unsure. This is a testament to the severe lack of attention that domestic violence receives. Our survey also showed that approximately 38% of those that experienced domestic violence experienced it both within the military and after they separated. It is well known that increased stress exacerbates instances of domestic violence, and the last year and a half have been extremely stressful for the veteran community. Even with this increased stress, messaging around domestic violence and intimate partner violence assistance from VA and DoD has been almost non-existent. Veterans continue to be some of the most resilient members of our nation, but despite our abilities to adapt and overcome the weight of a pandemic, the feelings of our military's withdrawal from Afghanistan, and many other situations can be a lot to bear. We must ensure that we are doing everything we can to help veterans through this difficult time. Members of the committee, I thank you again for the opportunity to share IVA's views on these issues today. I look forward to answering any questions you may have and working with the committee in the future. Thank you.
Thank you, Ms. Hedrick. I particularly appreciate hearing from IAVA today because your organization serves the cohort of veterans who serve and have served in Iraq and Afghanistan. Ms. Silva, I recognize you for 5 minutes for your testimony.
Chairman Takano, Ranking Member Boss, and distinguished members of the House Committee on Veterans Affairs, thank you for inviting Wounded Warrior Project to testify at today's hearing on veteran suicide prevention. Saving the lives of veterans is a central part of our mission here at Wounded Warrior Project to honor and empower wounded warriors. Sometimes it comes as an intervention during crisis, but most times as an interaction much further upstream to ensure financial security, improve healthy habits, foster greater connection in the community, or lead a veteran to their first mental health appointment. While veteran suicide has sadly always been a major challenge, it has recently been heightened, as everyone has said, by the COVID-19 pandemic and the withdrawal of the U.S. Armed Forces from Afghanistan. During this time, we have proactively engaged with the warriors we serve to address these challenges, and we gained insight into how these events have affected warriors. Over the first 2 months of the pandemic, we saw a 38% increase in referrals to our mental health programs and learned that most of the warriors we serve were feeling disconnected and isolated. We made almost 40,000 outreach calls to veterans during those first 2 months. That effort led to more than 50,000 hours of clinical care and conducting more than 7,000 hours of weekly emotional support engagements. The largest volume of referrals from those efforts were to our connection programs that connect warriors and their families with each other, their communities, and the Wounded Warrior Project. We're currently conducting the same type of outreach to warriors who were deployed to Afghanistan, and after more than 15,000 calls to warriors, we've seen that mental health programming is now the leading request. From a public policy standpoint, it's important to recognize your committee's commitment to improving the mental health landscape for veterans. The Hannon Act and Compact Act saw many of our top legislative priorities signed into law, most notably those to accelerate biomarker research for PTSD and traumatic brain injury, to expand complementary and alternative treatment options at VA, and to launch a new community grant program to help VA build stronger alignment with nonprofit organizations that are working tirelessly to prevent veteran suicide. As Chief Program Officer of one of those organizations, I'm pleased to share some of our insights that we believe will help continue guiding our community forward to prevent losing more veterans and helping those veterans ultimately thrive. First, we must continue to find innovative ways to remove barriers to care. Two key barriers are insufficient access to treatment for PTSD that co-occurs with traumatic brain injury or substance use disorder. Treating these conditions concurrently without a gap in treatment can be life-saving for veterans. After working with RAND to explore this gap, we are expanding intensive outpatient services for both of these co-occurring challenges through our academic medical center partners in our Warrior Care Network. We believe similar life-changing care can be provided through VA. Second, we must continue to recognize and invest in the power of peer support and connection. As a collective, we must create an environment where there is no wrong door to finding help. This includes training in suicide intervention for veterans, for peers, and the clinical and non-clinical professionals they are likely to interact with. Assist and Safe Talk are two programs that we've used, and they have saved lives. As VA extends its network through community care providers and new HANANAT grantees, we believe the same approach will save more lives. Third, we must continue to embrace and expand telehealth. When we pivoted to provide more virtual programming in 2020, we saw a great increase in our interactions with women veterans and veterans living in rural areas. As an even wider group becomes accustomed to virtual platforms, we believe that using this momentum to ease regulations on telemental health practice over state lines will be crucial to addressing mental health care provider shortages and connecting more veterans who may not use VA to access the mental health care that they need. Lastly, our written statement highlights a growing body of research about the impact of both sleep and physical pain on mental health. Veterans are at a higher risk for both poor sleep and chronic pain than those who have not served, and both conditions can exacerbate or increase the risk of mental health symptoms. We believe VA can do more to integrate physical activity and alternative and complementary programming into its clinical work. This will help address warriors' whole health, and we believe their mental health will improve in the process. Wounded Warrior Project thanks the House Committee on Veterans Affairs, its distinguished members, and all who have contributed their perspective and policy recommendations for reducing veteran suicide. We share a sacred obligation to serving our nation's veterans. I'm thankful today for the invitation to testify today, and I'm happy to answer any questions you may have.
Thank you, Ms. Silva. I want to just point out how pleased I am today. We have panels from both VA and VSOs on which women are well represented, as they should be. And now, Chief Smith, you're recognized for 5 minutes for your testimony.
Good morning, Chairman Tacanto and Ranking Member Bost, members of the House Veterans Affairs Committee. On behalf of the National Indian Health Board, thank you for the invitation to testify on veteran suicide prevention. My name is Chief William Smith, and I am the chairman of the National Indian Health Board. I am from the Eyak tribe of Alaska, and I'm also a Vietnam vet. As Alaska Native and veteran of Vietnam War, I can speak firsthand about the challenge in facing Native vets in getting care, especially during this pandemic. Native veterans continue to suffer among the world's health outcome and among the greatest challenges in the behavioral health than any other veterans. The United States has dual responsibilities to the Native veterans. One is due to our service to the nation's armed forces, and the other is due to our status as Alaska Native and American Indian people. Native veterans have served in every U.S. military conflict in the last 200 years. Our people serves at 5 times the national average and at a higher rate than any other ethnic. In 2019, the VA determined that there was over 217,000 Native veterans that used the VA for their health care. That is about 2.5% of all VA users. Many Native veterans receive their health care from both the Indian Health Service and the VA. For example, I have the primary care from Indian Health Service, and especially care from the VA. To give you a better picture of what we Native veterans returning home to, let me tell you about my experience. As a Vietnam vet, we returned home to a country which did not thank us for our service. We were not provided care for our wounded, mental, and physical, and we still fight for the care we earned from the VA for Native veterans. This was on top of the policies from federal governments, which tried to take our culture away from us. They did not provide us and our communities with basic resources like water and sanitation. The difficult situations can really harm medical health, and Native veterans struggle. And unfortunately, we have seen too many of our brothers and sisters in arms take their lives. Our people are 2 times more likely to suffer from post-traumatic stress disorder than the average American, and 84% of the Native women experience violence in their lifetime. These are just some of the challenges that the tribal communities continue to face during COVID-19 pandemic. Across the board, Native veterans report higher rate of issues around quality of care and access that hurt trust in the VA and left Native veterans with vulnerable and adverse health outcomes, including COVID-19. Destructional federal Indian policies and unresponsible human services systems have left these Native veterans and their communities with historical trauma affecting generations of our people. From 2001 to 2015, suicide rate among Native veterans increased by 62%. Native veterans suffer more higher rate of mental health disorders compared to non-Native veterans. It is essential that the Veterans Health Administration work with the Indian tribes and IHS and other federal agents to create more resources for Native veterans. Outreach events for the tribal communities would be a priority to increase wellness, decrease stamina and behavioral health, and prevent suicide. It is essential that the VA continue to engage with tribal leaders through consultation to support and consult on their activities. Culture information care is the first brick of building compassion. It improves the likelihood of building trust between patient and doctor, increases the likelihood that the Native veteran will seek care. As a tribal veteran representative, I've seen the need to speak to Native veterans and connect them with their deserved VA health benefits. Many veterans are too proud to ask for help they need and deserve, and we must reach them. It should include traditional approach, medicine, and method that have been practiced in Native communities for generations. Traditional healing as a different technique included physical, mental, and nourishment therapists that may be different from one Indian tribe to another. Culture information and care also includes the need to acknowledge the patient's background and recognize the history of trauma affected by Native veterans. This background should inform treatment plan and healthcare reforms and improvement. Without recognizing the importance of culture-informed care, we will miss some of the Native veterans that need help and will benefit important culture practice. It is very important that Congress establish parity between the VA and the Indian Health Service, especially for mental and behavioral health care. Without parity, the quality of care for Native veterans will continue to suffer and health outcomes will remain worse. Thank you, Awata, for your holding this important hearing and for inviting National Indian Health Board to testify. We have a long way to go to improve care for the Native veterans. We will serve in this way as well. Thank you, and I yield back time.
Thank you, Chief Smith. As you know, I've made it a priority for this committee to infuse all of our work with an emphasis on equity. And this includes not only access to care for all veterans, but a seat at the table for VSOs testifying on behalf of the traditionally underserved veterans they represent. Your testimony in many ways was heartbreaking, but so necessary for us to hear. So I'm so glad you're here with us today, sir. Mr. Armendariz, you are recognized for 5 minutes for your testimony.
Yes, sir. Excuse me. Thank you, Chairman Takano, Ranking Member Boss, and members of the committee. Thank you for your kind invitation to testify before today's hearing. My personal experience as an Afghanistan veteran and what I've seen in my dealings with the Independence Fund, both before and after I became an employee, mirror the concerns raised by the chairman about recent events in Afghanistan. In September 2006, I enlisted in the U.S. Army during my time on active duty. I was honored to serve 3 combat tours in Afghanistan, including some of the deadliest fighting in the Afghan war. While all 3 deployments saw heavy fighting and significant casualties, it is during my deployment with Bravo Company, 2nd Battalion, 508th Parachute Infantry Regiment, where we lost 51 total comrades to enemy action and 200 wounded, many severely. One of those, Sergeant Mike Verardo of the U.S. Army, retired now, is the husband of the Independence Fund CEO, Sarah Verardo, for whom she's his caregiver. I've seen the impact of the trauma suffered in these combat deployments, both within myself and with my fellow soldiers. For example, while the losses Bravo Company sustained in combat were significant, since that deployment, I know of countless suicide attempts, and 4 men with whom I served were lost to suicide. I left active duty soon after my 3rd deployment to Afghanistan and found myself feeling isolated and struggling with many of the same issues arising out of my post-traumatic stress and combat experiences that many of my fellow soldiers from Bravo Company struggle with to this day. In my case, I hung up my uniform and lost my identity, my family, and my tribe. I was lost in a hole, could not climb out. Some of the mistakes I made, unfortunately, put me in a bind legally and mentally, mistakes that ultimately put me in a position in which I didn't feel as though I wanted to be here any longer and considered an alternatively morbid path. I was lucky, an individual district attorney, instead of throwing the book at me, saw I needed a different type of help, personally intervened, and recommended Veterans Treatment Court. Because of that, I got a second chance that I will never take for granted. My situation emphasizes the importance which community organizations play in veteran mental health and suicide prevention. The VA needs to launch soon the community grant program this committee passed last year. Veteran mental health is also impacted by recent events in Afghanistan. The VA saw a significant uptick in August in veterans engaging VA mental health resources. The Independence Fund saw this as well, so much so that we co-founded a new coalition named Save Our Allies to evacuate Americans and Afghans to aid both the Afghan refugees in the United States and to support US veterans struggling to make sense of recent events. Unfortunately, when we refer veterans to the VA, we find many of them do not trust either because of perceived poor prior treatment or because of the stigma and law enforcement fears outlined in the National Academy of Sciences report. In the coming weeks, the Independence Fund will roll out the Independence Line, a professionally manned call center and hotline where both US veterans seeking mental health care and Afghans seeking refugee assistance can call and get assistance. One thing that must be discussed is the role combat deployments may place on veteran suicide risk. For the US Army, combat units operate at an incredibly brutal op tempo with combat deployments every other year. In my case, 45% of the 6.5 years I spent on active duty were deployed to Afghanistan, engaged in direct combat actions. The VA's 2016 annual veteran suicide report is the only report I can find where the VA so reported on combat veteran suicides. While I detail these numbers in my written testimony, the data indicates the 18 to 24-year-old male combat deployed veteran suicide rate is 2 to 3 times higher than the overall veteran suicide rate and 6 to 7 times higher than the non-veteran overall suicide rates. Similarly, I described the same increase in overall veteran suicides for the last 20 years in my written report, where 18 to 34-year-old veterans make up 77% of the increase in veteran suicides, but represent only 9% of the veteran population. Our community needs to further analyze this data and study the risk factors combat deployments contribute to veteran suicides. To date, the Department of Veterans Affairs has not provided the public the raw suicide data used in these reports, only age cohorts, which are too broad to allow for any truly useful analysis. This limits the ability of other groups to peer test the VA's claims and to conduct additional research to analyze the risk and protective factors involved with veteran suicide. I encourage this committee to direct the department to release such information and resume reporting on suicides by combat veterans. Chairman Takano, Ranking Member Boss, members of the committee, I thank you again for allowing me to testify, and I stand ready for your questions. I look forward to working with you both as an individual veteran and as an employee of the Independence Fund to work with this committee on these crucial issues.
Thank you. Thank you, Mr. Armendariz. I know I speak for all of us today in thanking you for the tremendous service you have provided to our country in uniform, and also thanking you for continuing to serve in the work you continue to do for the Independence Fund. It is very clear to me that you have endured great sacrifice and continue to face the effects of your service today. We owe you and every one of your brothers and sisters in arms support now, as long as you need it, as long as they need it. Mr. Ramchan, you're recognized for 5 minutes for your testimony.
Good afternoon, Chairman Takano, Ranking Member Bost, and members of the committee. Thank you for the opportunity to testify today. My name is Rajiv Ramchand, and I'm a senior behavioral scientist at the nonprofit, nonpartisan RAND Corporation, where I also co-direct the Rand Epstein Family Veterans Policy Research Institute. In my testimony today, I'm going to address 4 strategies critical for preventing veteran suicide. 1, improve the national mortality data infrastructure. 2, use data to better understand veterans' healthcare experiences outside of VA. 3, collect better and more comprehensive data on veteran firearm ownership and storage. And 4, incentivize researchers to collect data on suicide when testing novel and promising mental health treatments. First, the national mortality data infrastructure needs to be improved. The VA just released data on veteran suicides from 2019, meaning that our data is over 20 months delayed. Whether the impacts of COVID-19 or the withdrawal of US troops from Afghanistan have led to increased suicide rates among veterans are questions that are currently unanswerable due to the lack of timely data on suicide. To have more timely data on veteran suicides, resources are needed across the nation's over 2,000 death investigation jurisdictions to update antiquated systems, ensure investigators have the resources to conduct comprehensive investigations, and to more quickly and accurately transmit these data to CDC. Better quality data is also needed. Death investigations should routinely collect data on sexual orientation and gender identity, and investigators need to improve how data on race and ethnicity is recorded. This is especially important for American Indian and Alaska Native individuals who have the highest rates of suicide in the United States, but whose race is often incorrectly coded on death records. The second strategy for preventing veteran suicide is to use data to better understand veterans' healthcare experiences outside of VA. While we know much about the VA care that veterans are receiving, 75% of veterans receive at least some care outside of VA, and we know very little about this care. One place to start could be to focus on veterans who are receiving care through other federal programs, like Medicare and the Indian Health Service. Merging healthcare utilization data from these systems with data on veteran suicides would help identify when veterans who died by suicide last accessed care, the settings in which they received this care, and the type of care they received. These data would help identify where suicide risk may cluster within health systems so that tailored interventions could be created and implemented to address suicide in the places where it is concentrated. The third critical strategy I'd like to point out today is the need to collect better and more comprehensive data on veteran firearm ownership and storage. Over 2/3 of veterans who died by suicide used a firearm to end their lives. Many suicidal crises are of short duration, and experts argue that placing time and space between a person in crisis and his firearm by storing it unloaded and locked can be life-saving. Many suicide prevention strategies are focused on encouraging such storage practices, but without timely data on how veterans are storing their guns, it will be impossible to know whether these efforts are effective. The final strategy I will mention today is the need for data on suicide outcomes for novel treatments. As new treatments are developed and tested for patients with mental health conditions and substance use disorders, data is needed on whether these therapies specifically affect suicide risk. But currently, most experimental trials for new mental health treatments exclude individuals with thoughts of suicide or past suicide attempts. Proactive strategies are needed to actively recruit and monitor people with suicidal thoughts so that we can understand the benefits these treatments have for reducing suicide. This includes the trials underway for new treatments for post-traumatic stress disorder, like MDMA-assisted psychotherapy, ketamine, mindfulness, and stellate ganglion block. Too many Americans and too many veterans die from suicide each year. I am convinced that we can prevent many of these deaths, but we need to invest in data and science to do so. In my testimony today, I recommended 4 strategies: improve the national mortality data infrastructure, better understand experiences outside of VA, collect data on firearm ownership and storage, and test specifically whether novel and promising treatments affect risk. Thank you again for inviting me to speak with you today, and I look forward to your questions.
So I thank all of the witnesses for their testimony. I'm going to call for a recess and for the committee to return as soon as possible after the last vote of our 6 votes, which I say will be in about an hour and 20 minutes. So we'll resume in about an hour and 20 minutes. Members do need to proceed to the floor to cast their votes on the 6 questions before the House. And with that, I call a recess until the time that I mentioned. Thank you. I now recognize myself for 5 minutes of questioning. I'll begin my question with Ms. Bartlett. Ms. Bartlett, I'm very happy to see that VFW supports our legislation that will mandate more thorough training for VA's community mental health providers. And I was also struck by your testimony about the importance of including VBA and VA suicide prevention work. Can you say more about your position related to these, our legislation? Go ahead.
Yes, thank you, Chairman Takano, for that question. In regards to the community care partners, unfortunately, we've heard some barriers and challenges with our membership here in the last few months. And that barrier and challenge is that their VA VCCP referrals, and often that time it is from mental health, are being delayed in reauthorization. So that means for the veteran that the care is being delayed, or they may have to start back up with a new mental health provider within the VA. In regards to what we've seen with the VA's national survey, suicide report, yes, speaking on behalf of the VBA programs, we know oftentimes more veterans do use VBA programs than they do seek healthcare within VHA. This is a vital touch point that VA is missing out on. And we can see how programs have changed because we've seen the amazing things that have happened, especially when we're talking about education assistance over the past 10, 12, 15 years, and see how that's benefiting veterans and suicide.
Well, thank you. Thank you for that. It does make more sense that we have a lot more veterans using VBA, and that touch point is really important. Ms. Silva, I continue to be impressed with the breadth and depth of services that the Wounded Warrior Project has designed to meet many of the needs of your members through a continuum of care model. I know the WWP has studied the issue of your own members' substance abuse and treatment in depth. And can you say more about what you think VBA needs to do specifically to provide more accessible substance abuse treatment for veterans?
Well, we were grateful actually to work with Rand we didn't know what we were going to find related to substance use co-occurring injuries, substance use disorder, or traumatic brain injury. And so we looked at the space, including VA, and saw that the outcomes of services when they are provided concurrently and at one time, actually the outcomes are very positive. The problem is there's not enough of those facilities available to veterans. They have to go long distances. There's just not enough of them. So, and they looked at civilian as well. It's not just a VA issue. It's across the board. So, but we're very concerned with the gaps in treatment. When you treat substance use disorder sequentially before post-traumatic stress disorder treatment, which is often what is the protocol, you have that gap in services, that gap in treatment, and that's when warriors, veterans are most at risk. And so that's what the barrier that we were trying to tackle. And so we have been able to invest in that within our own Warrior Care Network facilities that will help and to be able to get that intensive treatment at the same time and treating the whole warrior at one time with substance use disorder, traumatic brain injury, and PTSD. I think it'll be really helpful if the VA is able to implement that on a broader scale. They do have that, that's just not enough geographically.
Well, thank you for that. Ms. Hetrick, I'm pleased that you're here to represent the VSO most closely tied to supporting post 9/11 veterans specifically. I was very interested to hear about IAVA's Quick Reaction Force program and your desire to see the Hannon, Deborah Sampson, and presumably Veterans Compact Acts implemented. What in particular do you see as gaps that remain for us to address to support veterans and your members in particular?
So as mentioned in my testimony, the issue of domestic violence obviously can contribute to veterans who experience thoughts of suicide. And as I mentioned, there has been almost no communication over the past year and a half when it comes to resources for domestic violence and intimate partner violence. So VA really needs to ramp up this type of messaging. There were veterans that were unable to leave their homes for long periods of time and may have been trapped in situations in which were not okay. And so making sure that VA really puts out enough information to let veterans know what resources they have and ways that VA can help them through those types of things.
Oh, well, thank you so much. I'm going to now recognize the ranking member. We'll go through a couple more rounds of questioning since there are very few members back. I definitely want to get to the witnesses who have made themselves available. So Ranking Member Boss, go ahead and take 5 minutes and then we'll switch.
Thank you, Chairman. Mr. Hernandez, as someone who served in Afghanistan and lost friends there, what has it been like watching the failed withdrawal over the last several weeks and knowing that so many veterans and allies were left behind? You're still muted. You're still muted. Thank you.
So it's interesting for, for a lot of us that have seen it and stuff, there's a mixed effort, and there's definitely a, indication that, this is a very stressful environment for a lot of these veterans that have spent the last 20 years overseas. And a lot of them, as it was stated before, wonder if it was all for nothing, which is case in point why, I had stated that, we at the Independence Fund had started working with a coalition named Save Our Allies, not only to evacuate Americans, Afghans from Afghanistan, but also to provide that assistance to both the Afghan refugees that arrive here and support the veterans struggling to make sense of the recent events. Unfortunately find that many of the veterans we serve do not trust the VA, either because of perceived poor prior treatment from the VA, or just they fear that the VA will report them to authorities or place them involuntarily into the fiduciary program.
So what would be your main message to any veterans that might be listening to your testimony today and your experiences and struggles? What would you suggest and encourage them to do?
I would encourage them to reach out to the VA crisis line, as well as, as I stated, in the coming weeks, the Independence Fund will roll out the Independence Line, which is a professionally manned call center and hotline where both U.S. veterans seeking mental health care and Afghans seeking refuge assistance can call and get assistance.
I appreciate that. Ms. Hetrick, you testified that the tragic events of Afghanistan over the last several weeks will have a lasting effect on veterans. What do you think the lasting effect will look like, and what do you think, how should VA position itself and this committee now move forward, pushing and making sure that the VA goes in the right direction dealing with this issue?
Thank you so much for that question. So as we mentioned, making sure that pushing out resources for veterans who are experiencing, who are being triggered by the events. The lasting effects could be a different opinion of the war in Afghanistan. As I said, our survey has shown a 10% decrease in veterans who feel that the war in Afghanistan was worth it. And then also just making sure that we support veterans, as many veterans are trying to still work to get the Afghan interpreters out of Afghanistan. And so putting out positive messages to ensure that they're being helped through this very difficult time.
Wonderful. Mr. Smith, just a quick question, if I can, for you, because you represent a unique ethnic group as well as Vietnam era. Have you seen an uptick after this problem in Afghanistan, and has it affected those Vietnam veterans to the level with your groups that we've seen with others?
Yes, it has. In 1975, we did the same thing when we withdrew from Vietnam, and you've seen how they just got the people on the aircraft to get them out there, but we left hundreds and thousands of Vietnamese that were our partners, just like we did in Afghanistan. We left our people that worked with us to fend for themselves And as a Vietnam vet, I see this as the Taliban coming over and taking over. You already seen it. Women's rights are completely useless. The veterans, they feel the same way. When I talk to my brothers and sisters that come back from Iraq and Afghanistan and all over, it's not the warriors' fault that we got out this way, but it hurts. We leave people behind. We left people in Vietnam in 75 when the tanks from north were coming down right into Saigon, which is now Ho Chi Minh City. Same thing at the airport. You know, the Taliban was coming in, and the people that we couldn't get out and can't get out, I don't believe some of them are alive today because of what happened and the way the withdrawal was. And as a veteran and someone that volunteered to serve in my country and serve in Vietnam, this is tragedy. And all the Vietnam vets, just like when we welcomed our brothers and sisters home, because we never had that, we also stand with them to knowing that what we did in Vietnam and what they did in Afghanistan was right. We kept the bear at bay. We kept him over there. But the way we were withdrawn is a disgrace. And is it going to hurt our veterans? Yes, it is.
Well, we want to make sure we're there for you with that. I'm a little over on my time. I will yield back. Thank you, Mr. Chairman.
Thank you. I see that Chairwoman Brownlee has joined us. Thank you, Chairwoman, for being here. I recognize you for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. And I'm sorry that I missed some of the testimony, but I had another meeting that I had to attend. But anyway, Ms. Hedrick, I wanted to ask you, in your written testimony, you talked about the risk of homelessness and the impact on mental health, and you specifically mentioned women veterans and veterans with families. And so last year, I had a bill signed into law to permit the VA to pay a per diem for housing homeless veterans with children. It passed, and I'm just wondering if you know if VA has begun any issuing of per diem payments for homeless veterans with children.
At this moment, I do not know, but I can definitely look into that one.
Okay. Yeah, it was to provide a per diem for the children as well. So when they go into the community and look for housing, they have the resources, hopefully, to secure that housing. So I'd appreciate it if you look into it, just to give me an idea of if it's actually being implemented or not. That would be terrific. So Chief Smith, how are you? And thanks for being with us. And I know in your testimony, you noted my bill, and I thank you for that, about requiring VA to train minority veteran coordinators in culturally competent care. And we know that our Native veterans have the highest suicide rate of any cohort within the veteran community. And so if I just wanted you to talk a little bit about culturally competent care and, probably the lack of culturally competent care, and what are the impacts and indications for that?
Thank you for that. Competent care, when we talk about going to our sweat lodges to cleanse ourselves and stuff like that through the traditional ways, the best way that I know for a veteran that's in crisis is talk to another veteran. That's where TVR's Tribal Veterans Representative in the urban setting for the health is trying to get us to talk to a lot of the Vietnam vets that never did come back to the VA, but to stand by our Afghanistans and Kuwait and all the rest of them, our brothers and sisters that comes home, by being treated with the sweat lodges and the traditional healing, like when a warrior comes back. Right now there's shame of how we left Afghanistan, and the people that served over there is an all volunteer army. They all volunteered. And back in my days, there was volunteers and there was draftees. I am a volunteer just like the rest of my brothers and sisters. And it needs to have in the Indian nation being able to work between the two systems, the Indian Health Service, the traditional medicine, the healing through the potlatches, through the drumming, through everything else to calm the warrior's spirit. When we come back, we're all hyped up. I mean, when you're back on the block, because you could, in my days, you could be in Vietnam and 3 days later, you're back on the block. Your body is still over there. My body is still over there. My mind is still over there as a young kid at 19. But coming back and learning from my warrior brothers, being able to talk to them. And the only thing that got me to start working at it is my brother was in Vietnam before I was. And it took us 35 years to talk to each other. And that's what it's going to take to do it, is another veteran talking to the veteran and saying, let me hear what your story is. Not tell you mine, but let me listen to you and show you how I found the road to recovery. Because me, after 4 divorces, 1 alcohol clinic class, and a couple of be nice to my neighbor classes that my company saw value in me, I realized that I was still back in Vietnam in 71. And how do I get home? Step by step. And that's what we're going to have to do, is make sure that our brothers and sisters know that there was someone to talk to. And hopefully it's another veteran to say, welcome home, brother. Welcome home, sister. Here is what I knew to care. And the other thing is we got a long number to call for help. You know, if there's an emergency, it's 911. If I need to dig in my property, I call 811 and I can get cell phone company, electric company, the water company, the gas company to come out and plot my land. Why can't the veterans have just a simple number to call instead of one that's, you know, we preloaded on our phone, but why don't we have a simple 3-digit number for a veteran to call in, and then it gets to a center that they can say, hey, I'm here.
Well, hopefully on this,
I'm over time, so
get to a 3-digit number at least. But I thank you for your response, and we're so delighted that you're here and with us. And again, thank you for your testimony. And I yield back, Mr. Chairman.
Thank you, Chairwoman, Chair Brownlee. And you know, I am so proud of the work. We are also proud of the work that you've been doing in Indian country and holding historic field hearing in Indian country. And I'm just really, I can't say enough about the work you've been doing. Chief William Smith, just know that the crisis line 988 goes live in 2022. We had some issues with getting the FCC approvals and all that. It's been a long time in coming. I know that there's been a big push from folks like you and other VSOs, but know that we have a 3-digit number, 988, that goes live in 2022. It's not operating now, so we still have to. That's why I said put on your phones the Veterans Crisis Line number, and I do it wherever I go. I announce it, and you saw Chairman Boss, Ranking Member Boss did the same thing. So I now want to recognize the gentleman from Montana, Mr. Rosendale, for 5 minutes of questioning.
Thank you, Mr. Chair. Thanks everybody again for joining us. Another wonderful committee we have here and panel. Mr. Armendariz, my first question is for you. I'm alarmed by the claims in your written statement that you regularly hear from veterans who cannot access mental health care through the VA and who are waiting months for an appointment and are not being given a choice to receive care in the community as required by the Mission Act. We heard testimony earlier today that that isn't the case, and veterans could receive treatment on the day that it was requested. So why do we have a discrepancy in these two descriptions about the delivery of care? And could you tell me about that?
Yes, sir. So I can speak on personal experience, and I can speak on lived experience, having seen, the treatment and that of fellow veterans and service members that I worked with who've been turned away at the door. But I will say, we regularly assist numerous veterans who either cannot get access to VA mental health care, do not trust it, and both should be addressed by the VA. More than 25% of the veterans we assist for mental health care refused our referral to the VA because of the mistrust or because of poor prior experience or medication management mishaps in the past. More than 25% were critical cases requiring de-escalation and safety planning, and highlights the fact that by the time the veteran asks for mental health care, they are likely at the end of their rope, not at the beginning. Almost 1/3 of all the casework requests we've received this month are for mental health care. With regards to those veterans who say they can't get timely access to mental health care, we have veterans who are told by VA schedulers they cannot be seen for 7, 8, or 10 weeks. When those veterans ask for community care instead, they are told either they shouldn't go to the community because it's not as good, or because the VA staff don't believe that they'll be able to get community care appointments for that veteran. And I'll say that just this last April, the Government Accountability Office reported VA suicide prevention teams are overloaded with cases, and that Veterans Health Administration has not conducted a comprehensive evaluation of local suicide prevention teams. Therefore, I'd say the Independence Fund recommends this committee actively exercise its oversight responsibilities on community care, find out how long the VA is taking to process community care, mental health care referrals, how long between the veteran's request for care and that care actually is being delivered. And if there are additional mental health care providers, which the VA is not presently using.
Thank you so much. And I will be requesting that information to make sure that we can fill those needs, because I don't like hearing different stories, if you will, from folks that are supposed to be delivering this care and then hearing that it's not, and getting discrepancies. Ms. Silva, I agree with the statement in your written testimony that stated, quote, warriors have individualized paths of recovery, so that it may not be optimal to engage all warriors with the same program or even in a linear fashion, end quote. Do you think that the VA's mental health programs offer sufficient flexibility to tailor treatments to a veteran's individual needs, including a more holistic approach, as you were talking about, considering the total health and pain and how that interacts with their mental health? And could you describe the process in order to do that evaluation and treatment?
Sir, thank you for the question. So I believe that the VA, their evidence-based care, their clinical care, if veterans are receiving it, has shown to be very impactful. I do believe, as we said in our written statement and our oral remarks, that having a more holistic approach, adding the augmented therapies, we are seeing internally, when we have warriors in our physical health programming, sometimes their mental health outcomes are better than our singular mental health programs internal to WWP. I know that if they take a more whole health approach, which that is the name of one of their programs, if that is more widely used, our belief, the data that we have shows that the warriors will gain lots of outcomes related to better sleep, better pain management, and increased mobility. We get very nervous about the increases in chronic pain and the decreases in sleep quality. So those need to be attended to in a whole health way by the VA.
Excellent. Thank you so much. And Mr. Chair, I do see that I'm at my limit. Thank you so much. I yield back.
Thank you, Mr. Rosendale. Let me just say, we know that there are wait times in almost every community, not just the VA, because the entire nation has a shortage of mental health professionals. That is why in the reconciliation markup, I was insistent on including at least 700 slots. I would have liked more. And those 700 slots for residency training for medical professionals is not just psychiatrists, it's other types of medical professionals, but also including other types of mental health providers. But we do have a mental health workforce shortage in the country throughout the nation. So the shortage, the shortage occur, the wait times occur not just at VA, it also occur within the community. It is anecdotal that VA employees have not referred people to the community. It's anecdotal, but from what I'm hearing, it does happen. So I'm not contradicting what Mr. Almendarez is testifying today. Let me return to Mr. Mervan for 5 minutes.
Thank you, Chairman. Ms. Silva, as Chairman of the Subcommittee on Technology Modernization, I read this with great interest and discussion in your testimony regarding telehealth. What are the ongoing barriers to veterans' access to telehealth that persist following the implementation of the VA Mission Act in 2018? And what congressional actions may be needed in order to improve such access going forward?
Thank you, sir, for the question. I think it can be kind of summed up in two ways. Number one, the side pact or the interstate licensure obstacles are a problem. We have warriors that if they're stationed around in and around Fort Campbell, Kentucky, they've got to drive to be in Kentucky if they live in Tennessee, and that state or in that base or post happens to be straddling both of those states. It's just, we need, I believe, some more common sense licensure agreement between states. We do have that shortage of mental health care providers. This can help with that. So I believe Congress can help by having the states recognize that and join the side pact and other measures to decrease the obstacles for interstate licensure. Secondly, building out the infrastructure so rural warriors can get broadband access to be able to get that telemental health. Two populations, Wounded Warrior Project, that really benefited from our virtual programs were women warriors and rural warriors. And so these were obviously rural warriors who had access to a virtual platform. We need to make sure that all warriors, no matter where they are, have that access. So I'd say those two things are really important for Congress to lean in on.
Thank you very much. Dr. Ramchand, I share your concerns with what we do not have sufficient data to assess whether specific veterans, such as the LGBTQ individuals, are an elevated risk of suicide. How do you suggest that we ensure such demographic data are collected during death investigations into potential veteran suicides? And do you have any specific recommendations for improving coordination among the VA, DoD, and the CDC in this regard?
Thank you for your question, Congressman. I do think there's evidence to suggest that LGBT individuals are at increased risk for suicide, as well as LGBT veterans are at increased risk from suicide. But this is done by, to be honest, some pretty kind of fancy statistics. We use national language processing to understand clinical notes. So I think that to start, we could have routine collection of sexual orientation data in VA. I think it's, as we were talking about culturally competent care, I think that is, providing culturally competent care, understanding how people identify themselves. During death investigations, there are trainings that are available on conducting death investigations and reporting on sexual orientation and gender identity. Los Angeles is one death investigation jurisdiction that currently requires all death investigators collect data on sexual orientation and gender identity. And I think that that's a model. And I think that we could use the evidence provided from Los Angeles County in their death investigations and their successes that they're having in doing it. I think sometimes it's just a barrier that people don't want to ask, but if you instruct them and show them that other places are asking these questions, are collecting this information, that's a pathway forward.
And then quickly, you also discussed in your testimony the potential for improving veteran suicide prevention by merging healthcare utilization data from a variety of sources, including Medicare. Could you explain the value of merging healthcare utilization data, as well as discuss any barriers at VA to levering this data to improve health outcomes for our veterans?
I'm not sure of what barriers may exist. I'm sure that there are technical ones, but I think that it's doable. And I think the value here is we know that there's so many veterans who receive care outside of the VA, many of whom are enrolled in federal programs. And if we can identify concentrations or pockets of risk when they last accessed this health care, where they accessed it, and the type of care, then we could really target suicide prevention resources to those settings. This was done really successfully with respect to emergency department care happening right now on screening for suicide risk within emergency departments, and then following up and providing those who are discharged from emergency departments, especially with self-harm, with targeted resources and care. I think it's a really successful model. There's evidence that it works and it reduces future suicide attempts. And that's kind of what I see the promise for doing this type of merging with other federal health systems.
Thank you. With that, I'd also like to, as I always do, thank all veterans for their service. I'd like to thank Chief William Smith for his service to our country. Thank you.
Thank you, Mr. Mervan. I now will recognize Representative Moore for 5 minutes.
Thank you, Mr. Chairman. Ms. Bartlett, it's heartening to hear about how the VFW post and across the country is stepping up, particularly in response to the failed Afghan withdrawal. What can we do to support the great work that is being done locally by state and local VSOs?
Thank you for that question.
It appears Ms. Bartlett's connection is frozen. Mr. Moore, why don't you pose a question to another?
Okay, yes, thank you, Mr. Chairman. I can do that. This would be a question for Ms. Hetrick. Your testimony notes that stigma still prevents many veterans from seeking the help that they need. What more should VA and this committee do to combat that?
I feel like this gets said often, and I've probably already said it, but messaging. The stigma probably stems from the fact that within the military, when you seek mental health care services, you're often told that you are at risk for losing your ability to be deployed, or even at risk for losing your career. And so the stigma then carries into the veteran community. And so if we can help active duty service members know that seeking mental health care is not going to cause them to lose their jobs, then I think that that's really going to carry over into helping veterans feel comfortable seeking mental health care. Again, with the messaging, making sure that VA and VSOs are putting out effective messaging about how great VA services are, how highly rated they are. As well as ensuring that VA works with the community groups to ensure that the veterans who are not seeking care at VA are still being helped.
Thank you. Mr. Moore, it looks like Ms. Bartlett is relogged on, so if you would.
Okay, yeah, thank you, Mr. Chairman. Ms. Bartlett, did you hear the question okay, or did I need to repeat it?
Did she disappear again?
Okay.
There she is. There she is. Ms. Bartlett, do you need the question repeated for you that you were going to answer?
No, I do not, Chairman. Thank you. Thank you, Representative Moore, for that question. Like I mentioned, be involved, reach out, find a Facebook group that your VFW or other VSO posts may be doing. And oftentimes it's not even a veteran service organization. It could be a local church in your area who have taken upon themselves to help out in the community towards helping these refugees settle here in the United States.
Mr. Moore, go ahead and continue.
Okay, so I guess, and my question specifically is I think that we're going to have trouble with some of the veterans, I'm afraid, as the Afghan, we had a lot of interpreters at Fort Rucker that work closely with our soldiers. And so I think as a group, we need to be mindful that we're probably going to have, and there may be, I think it's already been reported, there have been increased calls. I think the ranking member mentioned that, to some of our veteran help organizations. And so that was kind of the thing I was wondering, what could we do to support the VSOs going forward to make sure that you have the support that you need to make sure that it's going to be increased calls. I think there's going to be increased incidences going forward based on what I'm hearing in the district around Fort Rucker and Maxwell County. And then with that, Mr. Chairman, I'll just yield back my time. Thank you.
Thank you, Representative Moore. I now call upon Dr. Ruiz. I recognize you for 5 minutes.
Thank you, Mr. Chairman, for holding today's hearing on such an important topic. Veteran suicide is far too pervasive and something that Congress and the VA must continue to stay focused on. We owe it to our service members who have risked their life and health to take care of them when they come home, and that includes their mental health as much as their physical health. One of my staffers, a previous wounded warrior fellow of mine, Blake Weller, is a Marine who served in the 2nd Battalion, 7th Marine Regiment. That unit lost 20 Marines in combat and 37 to suicide once they came home from Afghanistan. Let that sink in. He lost 37 fellow Marines and corpsmen after they were back in the United States. It's a heartbreaking experience to say out loud, let alone live through, and it is unacceptable. I know that the VA has prioritized this issue, and I want to make sure that Congress is doing everything we can to support those efforts. One thing that has struck me is that as part of the VA's suicide prevention effort, there seems to be an emphasis that is put on the individual to advocate for themselves. For example, the Veterans Crisis Line helps connect veterans to care and peer support networks, but it requires the veteran to proactively make that phone call. I've also heard from veterans in my district that when they seek mental health treatments at VA facilities, they must explicitly mention suicide or self-harm in order to receive rapid attentive care. So while this may not be the official policy of the VA, it is the experience of the veterans that I represent. Ms. Hetrick, as a doctor, I know that patients aren't always forthcoming. So forcing veterans to explicitly state suicidal intentions to receive treatment isn't a viable solution. In your view, how can the VA improve the experience that veterans in my district are having when they need help, but may not be explicit about suicidal thoughts or self-harm?
Thank you for that question, Dr. Ruiz. I'm not 100% on how the VA could be, I guess, a little help a veteran communicate that and get more effective care in that type of situation. My guess would be, I'm also not a clinical provider, but my guess would be that when a veteran does mention anything to do with mental health in one of their appointments, that there be more of an emphasis on getting them care at that moment instead of waiting for them to have to use trigger words like suicide or self-harm. Obviously, if they're bringing up the fact that they are struggling with something mental health related, then they are to the point where they feel that they need to bring it up often. We don't bring up those types of things until we're really feeling that push. And so when they are choosing to bring that up, making sure that that's taken as effectively as it would be with the previous statements.
Thank you. And I understand there's a need for additional mental health professionals to meet the demand from America's veterans. And earlier this year, I wrote to the House Appropriations Committee supporting a significant increase in funding for the VA Suicide Prevention Outreach Program. I'm pleased that the fiscal year 22 military construction VA bill includes a $286 million increase for suicide prevention outreach, almost doubling this program's funding. It's critical that we get this right. The VA must get to veterans before they have reached a crisis point. And I think a big part of that is helping to reduce stigma around mental health issues so that veterans feel more comfortable seeking help in the first place. Ms. Silva, how would you recommend the VA use this additional funding to reduce stigma and proactively reach veterans?
I do believe a public awareness campaign would be great, showing that it takes a lot of strength and it's actually an action it's actionable and it's a strong action. But investing in the peer connection across the different communities is really an important upstream intervention. And if a peer is telling you that they got help and that it worked for them, that's the biggest.
Thank you.
Yeah, it's really important. And the more that there's peer connection and that they see stories and buddies, battle buddies who do that, I think that can really be the best PSA for getting
Thank
good
you.
care, whether it's within the VA or other opportunities.
Thank you. I thank you all for your incredible work. Mr. Chairman, I ask unanimous consent to submit this New York Times article from September 19, 2015 about the 2nd Battalion, 7th Marine Regiment for the record.
Without objection, so ordered.
Thank you, and I yield back my time.
Thank you so much, Dr. Ruiz, for that enlightening line of questioning. It brings to mind something that we know from research, that when someone you know dies of suicide, your own suicide risks increases. And this is why it is this phenomenon of suicide actually being contagious. And that is why evidence-based prevention is critical to lowering everyone's risk of suicide. So thank you so much, Dr. Ruiz. Ranking Member Bost, I am loath to not do a second round of questioning because we have such an assemblage of expertise here today. It takes a lot of effort to bring them together, but we do have a markup in O&I that we've got to get started. And it's with a deep amount of regret that I don't do another round of questioning. That we normally have done that to take advantage of the tremendous expertise. I thank our veterans on this panel for your service. Always moving. Chief William Smith, I can't say it enough to you because we didn't say it to you then. Welcome home, brother. Welcome home. Welcome home, Nick. We thank you for your service. And, you know, we do stand in solidarity with all the veterans across our country who have been triggered, who have been, you know, especially suffering since the withdrawal from Afghanistan. So we thank all of you for your service. And I want to thank all 3 of the women veterans as well who are with us. You know, Ms. Hedrick, Ms. Silva, and Ms. Barlett. Thank you all for your service as well. And thank you for all the work that all of you continue to do for our veterans. And thank you for the service you've rendered to our country.
Mr. Chairman, can I?
Of course, Mr. Ranking Member Bost, I wouldn't want to adjourn this meeting without asking for you to weigh in.
Thank you. And I'm grateful for the opening dialogue, this hearing and the time of our witnesses, and in particular, Mr. Mendez, to take and share your thoughts, and Chief, yours as well, with the committee. I also want to apologize to the witnesses on our second panel who had to wait through a very long vote series. That's kind of how this place is, and our witnesses' time and testimony is valuable. I don't want you to think it's not. And I hope the chairman and I can work together and as we move forward to try to respect that, even in a time when we're doing markups and everything like that. But I don't want anyone, and in particular, any veteran who's invited to testify before this committee to have to wait hours for the opportunity to answer questions for their representatives. And that being said, it's very clear after all of you have delivered your testimony that we've done a lot of good work that we should be proud of, but it's also clear that there's a lot of good work still to be done, and we need to keep working together. And I look forward to continuing to do that work until not a single, I say that again, not a single veteran is at risk of taking their own life. And to the fellow veterans, I want to say this: I know times are tough. We all have struggled. There is no shame or weakness in admitting that you're going through a hard time. There is no shame or weakness in asking for help. No matter what, suicide is never the answer. And if you think that it might be the case, I beg you, and I'm going to say this, we know that the 3 numbers are coming in a few years, but right now it's still 1-800-273-8255, press 1, or text 838-255, or visit the Veterans Christ Lines. You are not alone, you're worth it, and you matter. And with that, Mr. Chairman, I think we had a great hearing, and I yield back.
Well, thank you, Ranking Member Bost. Thank you for being such a relatable peer, a peer who is reaching out to other veterans. You are exemplar of our peer outreach specialists who serves on the committee. And thank you, all 6 of you who are veterans. Thank you, Mr. Ramchan, for also your expertise today. My heart goes out to all the veterans across the country, and my gratitude to all of you all for serving our country and continue to serve our country. So thank you. Thank you, Ranking Member. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. Again, thank you for appearing before us today, and this hearing is now adjourned.